Let me just start by saying, for those of you who haven't heard me before, don't get too angry. Gary, as usual, has asked me to be as offensive as possible. And I'm already offensive enough as it is. Actually, I've never agreed with any endodontist that I've been opposite sides of the panel with as much as Rick. And I think that's largely because Rick has a restorative background as an excellent operative dentist, and I read his textbook. So my first foray into this was at a study club I belong to that Gary is a member of. We meet once a year. There's 25 of us, and we have very open and often violent discussions with each other. And then that's in the morning, and in the afternoon we're all friends again. But it's really a great learning environment, and so that's where I met Dick Burns, who sadly has passed away, but was a great friend of mine. I got to know him personally and professionally. And when I was one of the early people in there to talk about implants, and so that's really part of my job at USC. I initiated the implant dentistry program there. I just finished my residency, 1986. Terry Donovan hired me. He was the chair of Restorative. And then he said, "What is this implant shit about?" And I said, "It seems to work. There's quite a bit of data on it." And then he said, "Well, let's establish a department." And so we did. And I was the first guy up there, and it was a very rocky start. It was a turf war between the oral surgeons and the periodontists. So I was like the referee, and I fixed the problem by telling the then dean that, "Listen, let me control the patient pool. And if either one of these surgical services pisses me off, then I won't let them have any of the patients." So since then, we're one of the few programs in the country where we all work together. So that was pretty good. Anyway, so I met Dick Burns, and I started showing presentations for implants, and he said, "Oh, this stuff doesn't work. Everybody has tried that." And he was thinking about the subperiosteal implants and the blade implants that used to be done that all failed. And I said, these guys are a little bit different now. It's not like carpentry anymore. They've done some research and data, and he said, "It doesn't work. So this went on for many years at CAIC. Every year I would see him, and he'd look at me and say, he would say, "Implants don't work." And I would look at him and I say, "Endodontics is a specialty built on a myth." I say, "You can't disinfect the canals, so, get with it. I mean, look at your own book and look at the canal systems." And then, so that would go on. And then finally, he said, "Okay, let's have a debate, you and me." And at that time, we were using slides, right? So I prepared 2 carousels of slides, and he prepared a bunch of slides, and I got to advance the projector twice. And that took up the whole morning's discussion. And it was actually one of the best things that we did. At the end of that, we agreed that it's not the endo that fails, it's the tooth that fails. And Rick clearly said that in his presentation. And that's what's borne out by our experience and borne out by the literature. What's the predictor of survival? It's the remaining tooth structure. So a number of years go by, and usually we don't like to let too many endodontists in the group. But I don't know how Gary got in. So now Gary is part of the group, and he's into microscopes at that time. And he says, "Well, with microscopes we can cure all the ills of endo." So then we go at it. And again, at the end of the presentation, we don't have that much of a disagreement when we actually show cases. right? We don't have that much of a disagreement. We're, the deciding factor is how conservative the endo is, right? And how much tooth structure is left from the disease in the mouth. And really that was that's the conclusion. Now, I've also been on panels with some of the people that Rick was talking about, other program directors of endo, that are totally defensive. And they want to play the numbers game with us, right? And this will really hurt your ears, but I'm going to tell you, unless you do recalls, you have no perspective to have this discussion with me. You don't have hygiene practice. I have a hygiene practice. You don't know when I extract the tooth. You think everything is successful. Anybody want to argue with me? How many of you in your residencies read the implant literature? All of you? Implant literature. Almost nobody, right? Right? I mean, I had that discussion with not the current program chair, but several of the previous program chairs at USC. I've actually had someone tell me, my daughter had an implant, it failed, so implants don't work. Right to my face. So I asked him, have you read the literature? He said, no. I said, then we shouldn't even talk to each other about implants. And as a program director, we have a treatment planning seminar every Thursday. Perio is there with faculty, Pros is there with faculty, oral surgery there is with faculty, one of the years of ortho is there with faculty. Is endo there? Is endo there? Has endo been invited to the treatment planning seminar? Every new program director, the first thing I do is go up to them and say, we'd like you to participate in treatment planning. Do they come? No. One of them says, can we send our residents to audit? I said, no. You register for the course, right, because they're evaluations. You take your turn presenting, and we need faculty there. He said, why? I said, because your residents will go back and tell you that we are unnecessarily removing teeth without learning the rationale. Let me add insult to injury, okay? And some of you are USC grads. I know Scott was there, and Scott will confirm or deny whatever I'm saying. Scott is not shy of giving you his opinion, right? Endodontists want to get in on the game with implants. I have no objection to that. But my comments were you can't place implants in a vacuum, so you need to understand the context that we're doing things, and then we place implants. After all, we're training our undergrads to place implants now. They attend class, they have a treatment planning session, they evaluate CTs, they understand the difficulties, but endo wants to place implants in a vacuum. As much as you guys criticize your colleagues for teaching generalists to do implants on the weekend, you want to do the same thing with implants. So, gentleman there was talking about being two-faced. What's the specialty of endo doing? Is that two-faced? Right? And to address what Rick was saying about the patients, about how people have a double standard, the cases that Rick has shown, and I want to actually expand on that, are single tooth cases. We have no problem with rolling dice on single tooth cases, whether it's a family member or not a family member. But when an endodontic treated tooth can affect a reconstruction, and that means a segment, not just the whole mouth, then it's an issue. And there we become very aggressive. So I will tell you, in general, when I am not placing implants, or it's just one tooth involved, I'm actually pretty conservative. You can ask the endodontists that I work with. But once I start placing implants in a segment, the question is, why do I need the teeth in the long term? What is a stronger unit that can support my restoration? Okay, so let me just start again. So when we are treatment planning, we don't want to know what we're going to do, right? And this is the way we train in our program, which is not typical of a lot of prosthodontic programs. We train our residents to ask questions. And the guy with the longer list of questions is the winner. Meaning, for every procedure that you do, you have to do a PICO analysis. Problem, intervention, comparison, outcome. And that's why you as a specialty need to know about implants, not just endo, and you need to know about restorative dentistry. And you need to know about the survival of the restoration, no matter what's underneath, whether it's an implant or a tooth. So you have a problem, and I'm going to show you a series of cases which Gary has asked me to do. There's a problem. The intervention can be do nothing, right? Do nothing, do endo and whatever comes with the endo, extraction and implant, right? And then, or maybe there's some other procedures depending on the cases that will jog my memory when we show up. And then outcomes. We have to know what the outcomes, what's a reasonable outcome, right? And then over and above that, we have to do a risk benefit and a cost benefit for the patient. So what is the risk compared to the benefit of doing something? You'll see that we save some teeth that are pretty precarious because the benefit of doing the procedure in those particular situations outweigh the risk. The same tooth in a different patient's mouth, the tooth comes out because the risk outweighs the benefits of whatever procedure we're doing. So you have to look at all those things, and endodontists, if I were to ask for all your referral forms here, most of them will be prescriptions. You don't want to do that. You want to be part of the team, right? You want to be part of the team. Are there going to be some really shitty restorative dentists who just put the restoration on and then send it to you, and what they actually want you to do is save the restoration and save their ass? They are not interested in the quality of the work or taking care of the infection. They just want you to just get rid of the pain so their restoration lasts till the next insurance cycle. Now tell the truth. A number of your referrals do that. And what are the schools doing now for money? They are making deals with the capitation plan, so they send the patients in to get the endo done, then they go back out, and they have no idea what happens to those teeth. And those are purely by prescription. Some of the residents at USC don't like to work with advanced pros because we ask questions, we ask for certain things, and they just want to whack and pack because that's what they do for these cases that come in from the outside. They don't see anything. They don't see what's happening. Is anything that I'm saying sound like unreal to you? I mean, speak up. I don't mind having a discussion because I've done this so many times before. Any disagreement? No, speak up. I actually don't have a problem with discussing these things. Okay, so that's why, if there are any educators here, it's so important that changes. Like, I have zero objection to endodontists getting involved with implants, but it just can't be that mechanical part that you learn on the weekend, right? It just cannot be that part. You have to look at everything in context. Okay, so let me just move ahead. So, whoops, is this working? Yes. Okay. So I was asked to do this by Jennifer, I think, for TDO. I have to put this up there. Neither I nor members of my immediate family have any financial interest in the content of this presentation. So I would also say that I may be one of a handful of people that actually talk about implants in this country that's not on the payroll of an implant company. So I would also tell you that all the implant companies are lying to you, and basically whoever represents them just wants to sell you parts. Okay, so every implant company is trying to tout their product. It's all bullshit mostly. Yes? It's fine. I've been sued several times by implant companies. It's not an issue. It's not an issue. Because there are several very good publications done, actually by Steve Eckert, if anybody wants to look for them, where he asked implant companies to send in their best evidence, and then he did an analysis of those things and basically found out there's no difference amongst all those implant companies. So implant is just a screw, and it kind of works, but you have to know what to do with it before it works. I mean, all those bad examples that Rick showed up there, you can't argue with them, but what you have to understand is that implant is different than a tooth, meaning most of our teeth erupt in good shape, in bone, with no, without any issues. But an implant is something that we put in there, and a lot of what Rick has shown is iatrogenic. So just like you have bad endodontists, we have very poor practitioners of implant dentistry. So, you have to understand that implants done well, I think, are one of the best tools we have in taking care of patients now. I mean, everybody has their own list, right? But for me, the three biggest improvements or biggest things for dentistry, not just restorative dentistry, were fluoride, local anesthetic, and then implants. I don't know what your list is, but those things have just totally changed the course of dentistry, right? For me, in my perspective. Everybody has a different thing. So I don't have any financial interest to disclose. I further want to declare I don't have any conflict interest to declare, but I'm actively looking for a good one, okay? So I'm no angel, but just for a free aeroplane ticket and free dinner, I'm not going to prostitute myself. But if you give me enough money, I say, what do you want me to say? I'll just. But they haven't met my needs yet. So, Gary Carr is really an interesting person. I mean, he's actually a mad scientist. I don't know why he did endo. Any of you who visited his house and go down to the basement, you'll be just shocked at what he does there. And getting to know Gary has been really a great thing. I mean, very, very refreshing. Gary is an endodontist, but if you ask him, are you affiliated with any university? He's affiliated with USC. If you ask him, are you in the endo department? He'll say no. He's in my faculty in advanced pros. He's in my faculty in advanced pros, right? And so it's great to have Gary. Once in a while, Gary comes up, gives everybody a wake-up call. And it's not so much the endodontics, but is what Gary brings in with his passion, with his curiosity, that drives us. So, it's a great addition. I've played squash a couple of times with Gary. That's another thing that we have in common. I'm originally from Singapore. I was very keen playing squash. And I show up in San Diego for a TDO meeting and go to Gary's house, and he has a squash court. He was actually living in the squash court at that time. When he was renovating that end of the house, when the rest of the house was flat, that he rebuilt. And so borrowed a racket and a pair of shoes, and we had a game. Gary is pretty quick on his feet. I mean, you guys might not believe it, but we had a pretty fun game. This is Gary at CAIC. We meet off and on, and at that study club, he's brought a couple of people here to that study club, and I think anybody if Gary gives you an invitation, make sure you take it up. It's great fun, and violent discussions are always there. One time we came down to San Diego. When was that, Gary? This was in your old facility. And so Gary's presenting. You'll see Bill Becker there, Keith Phillips, John Coyce, Bob Winter. These are not lightweight people. These are some of the world's best at what they do, right? And we get into a room and we scream at each other. And it's really very, very productive, okay? It's great fun. And Rick has been there, Scott's been there, John Kademi's been there, Gary's been there, Sashi's been there too. Oh, anyway, so it's been fun. This is our last one. Gary didn't go because he was preparing for this meeting. This is the last time. This is in Assiniboine. I just want to put this picture up there so Gary sees what he missed. This is Mount Assiniboine. It's in the Canadian Rockies. You either have to hike in, which takes about 10, 12 hours, or ride the helicopter in. Most of us rode the helicopter. I don't think so. You might get eaten by bears. There's one thing that you need to learn when you go to these places. You just need to be able to run faster than one person, because that's who the bear is going to get. Scott was there, and that was a good time. Anyway, so back to teeth. So anyway, I just want to flash through a bunch of pictures. This has got nothing to do with what we're discussing, but some very, very old cases, and just show you that on these particular patients where teeth are already missing, it's a no-brainer, right? And we can actually place implants. We control the implant placement. We plan ahead of time. We understand the limitations that we have. We go in and we make provisional restorations. We understand that we can use the provisional restoration to actually direct the healing of the soft tissue. And then you can see the healing, of the soft tissue, the implants way down there. And then when you finally put the restoration in, they are in there, and they're in there for the long haul. Okay? The second thing that you want to understand is that unlike many of the other programs, and actually 90% of the people in the country, we do not cement these restorations in there. Okay? We have never cemented these restorations in there. I don't understand why anybody would cement an implant restoration in there. Because cementation on a tooth, you have a barrier there. If you cement on an implant, there's no attachment. There's no soft tissue attachment. The cement goes right down next to the implant. Eventually, that cement gets colonized by bacteria. It becomes a biofilm, and then it produces problems. That toward the end of my presentation, I'll be talking about peri-implantitis. And, is that really a disease? Is that really a disease? And most of the articles that Rick put up are by a guy called Todd Berglund. And Todd Berglund, we've had him at USC before. One of my residents has actually done a PhD in Gothenburg with Todd Berglund. And he might be the inventor of the disease, or the so-called disease. And you can see some dissenting views about whether that really is a disease entity or iatrogenic, right? So let's just take a look. We also are able to work on the soft tissue and the pontic areas to get restorations that look pretty good and are durable, right? So we're getting better and better at these things. For single teeth, it's actually a no-brainer. We'll discuss that. And if you know what you're doing, if you follow, if you understand the principles, they're actually very, very predictable restorations, both for longevity and aesthetics, right? And we do this fairly routinely. This is another one. This is actually a dental student. She went skating, she fell down, break the tooth. It's fractured below the tissue level. Extract the tooth, place the implant, place the provisional, right? And then this is the outcome of the restoration. So when you begin to look at these situations, and it's hard to bring everything in there, but I'll address these as I go through the cases. You have to begin understanding, like asking the questions, okay? So problem, intervention, comparison, outcome. I think that in this particular situation with this fracture that goes way down the root, I mean, there are ways of saving this tooth. You can do a forced eruption, you can do endo, and then you can have a shortened root. You can put a post, you can put a crown. You can do that. But you then have to also look at whether the root is tapered, whether the neck of the root is going to be the same size as this tooth, the time that is going to happen, the duration that you'll be in treatment, and weigh everything. Where's the patient's lip line? How old is the patient? What is the biotype? And so until you begin looking at all those factors and asking all those questions, you're not going to be able to get the answer. So in treatment planning, in every situation, we don't look for the answer. We want to ask the questions. And how does one variable affect the other? And that goes all the way to the patient's health history, right? So one of the first questions that you always ask is, why is the patient here? That's a question that's very important for endodontists. Why is the patient here? Meaning, what is the patient's problem? Right? And why is the patient here? What is the diagnosis? Not just locally to one tooth, but in general to the mouth. Right? Why is the patient here? And we'll show a couple of other cases, and we'll try to develop that. Right? So here we are looking. So you're looking at the biotype is a thick tissue. So you know that you're going to fairly predictably get a nice soft tissue reaction. You look at simply the periapical, and you look at the attachment level to the adjacent teeth. And if you know that, then you know that you're going to have the papilla, right? You have the soft tissue. Then all that remains is positioning the implant in the right place and then putting something in there that will shape the soft tissue. Now, I want you to note that almost in every patient that I show you, actually maybe every patient that I show you, there's nothing put in there. What is the routine now for many people, including some people in TDO who place implants? You extract a tooth and you put some smudge in the socket. What happens to that? What are you putting in the socket? Does that become bone? And if it does become bone, when does it become bone? So I'll tell you that in our center, we don't put anything in there. We don't put anything in there. And I'll show you result after result after result, that it doesn't seem to make that much difference. In fact, anything you put in there retards wound healing, right? So there are some differences that sorry, this is a provisional that was here. This is a provisional that was here, and then this is the definitive restoration, right? So pretty straightforward, very predictable. Okay? So let's look at longevity. Okay, some of you at the back can't read, but basically this is an email from one of my perio residents from USC. I treated this patient about 17 years ago, lost track of her, showed up in his office. So he took a couple of pictures for me, he sent an email and he said, everything looks good. 17 years ago, I dug up some old slides. This is how the patient came in. Recalcitrant periodontal disease, treated a couple of times, and then at that time we weren't using some of the materials we're using now. We made an overdenture, and so this is a patient before. There was an overdenture prosthesis. But what I want you to notice is this is not the best radiograph to look at implants, but look at the bone level on those implants, almost 20 years. 20 years ago, all we had was a machine surface implant with the external hex. And so I can tell you that there's not been a lot of improvements to implants from 20 years ago. We have better components now, we have better restorative materials, but the implants themselves, whatever you hear from these guys is mostly marketing, okay? So, but these implants, they work very well, and this is a periodontally susceptible patient. This is a periodontally susceptible patient, right? So, I'm going to show you some other patients. This was a patient that we did early on. This is way over 20 years. We didn't know what we were doing. We actually put the patient in before she stopped growing, and you can see that The other teeth have grown and the implant is up there. That's kind of a no-no. We wouldn't do that now. We could change the restoration, but the patient is doing okay, and these other teeth that actually erupted opposite the antagonist. So we put the implant in a little too early. The patient was, I think, about 17. We thought it was ready, but she continued growing. But that implant's in there. There's no bone loss on there. It's almost a 20-year recall. This is a guy, actually, Gary, you would enjoy knowing this guy. One of the best squash players in Southeast Asia, was a friend of mine. He came visiting. We placed these implants. This is over 20 years ago. He's back in Singapore. One of my residents, another guy from Singapore came, did our residency, went back, and I asked him to go see Derek, that's my resident back there, and get a radiograph, and that's the radiograph of implants 20 years ago. So, these things have a pretty long lifespan. So now I'm going to show you some cases that we've treated in our school, in our program, where there are actually large-scale reconstructions, all right? So if you look at this patient, this is a patient in 1996, and there are 3 implants that were placed, okay? So I'll tell you that as we evolved, we used to use implants as a last resort, okay, which is what a lot of you as endodontists are thinking, right? Let's throw everything at the tooth, and then, okay, at the end of it, if they need to put an implant, they can place an implant. But I'm going to show you what it does to larger scale reconstructions, right? So if you look at these 3 teeth, these 3 are implants. The close-up of this, and that's the patient in 1996. You can see some of the teeth are prepared. This is in provisionals. We want to make sure everything is okay before we put on the restoration. And then here is the reconstruction. At the time we're using partial dentures. You can see they're screw retained. Those of you who are familiar with implants can see how old this case is, because we're still using slot screws. Right? Nobody has used slot screws for a long time. They all have some star pattern or hexagon or something, but you can see how old it is. But let's look at the patient in 2011, right? You can see all the problems with the teeth, right? The patient has lost some other teeth, but look at the implants. So the question that you have to ask yourself, okay, you all think that we remove teeth without thinking carefully about it. Okay, that is absolutely untrue. We ask a series of questions. We ask a series of questions, like how did the patient arrive at this point? Is the patient failing biologically or mechanically? Right? If I am placing 3 implants and I distribute them better, can I replace more than 3 teeth? Because that's what the patient is going through with 3 implants. Guess what? With 4 implants, you can restore a full arch. With 4 implants, you can restore a full arch. Think about that. Right? So today, and there's plenty of literature that supports that, by the way. It's not just me blowing smoke. There's plenty of literature that supports with 4 implants, you can restore a full arch. So 2011, you can see that these 3 implants are doing really well. So what do you think is going to happen to the patient when the patient comes back now to USC? Are we going to start treating this patient 1 tooth at a time? There's decay on these teeth, right? Look at it, 1996, 2011. These are just the close-ups. Right? I mean, and I can tell you that almost every implant, anybody that deals with implants can show you these things, especially if you have these older patients from the 1980s and 1990s. Now, going forward, I'm not sure they can show you so many things because they started to take risks. They started to place implants immediately. They started to place bone grafts in the socket. They started to load immediately. All those are risks. Do we do that? Yes, we immediate load once in a while, but does the benefit warrant the risk? So you always have to do the risk-benefit. So if somebody tells me I immediately load every one of my implants, then I say, you must be an idiot. Right? If you tell me that there are times when I accept the risk and I immediately load, say, me too. We're friends. Right? But if you say, I always do something, you're an idiot. Right? So, can I be more clear? But anyway, so this patient then, this is what the patient looks like when she comes in. So this is what the patient looks like next. Does that surprise anybody? Those implants have lasted 15, 16 years. The teeth have dissolved. Patient has decay. Restoration has failed. So on this particular patient with a history of teeth failing, would I redo a reconstruction on teeth? Is it, how shall I say, is it cavalier of me to remove teeth that are still attached to the head for this patient? I mean, I'm just asking you to think about it, because truly what Rick said about endodontists being defensive is true, because I've been opposing some people who just, well, you can do this and you can do that and you can put implants in one at a time. You know how expensive that is to place one implant at a time when 4 implants can restore a full arch? And today with CAD/CAM, if I have time to show you anything, we can restore a full arch with a full arch zirconia restoration actually pretty reasonably, pretty inexpensively. And you know what you can do with CAD/CAM, which is this computer-generated stuff? If the restoration ever breaks, I don't have to take another impression or anything. The file is stored in the computer. You just press another button and you have another restoration.
How much is that?
Probably when you do it the first time, the restoration, it depends on the configuration of restoration, but the full arch restoration on a lab fee is probably about $3,000. The second time you do it, it's half that, because all the work is done. You're just paying for the material. On a puck, like a hockey puck that's this big, they can machine 2 full arch restorations, and a whole bunch of single unit restorations. And that cost of that puck, the most expensive one, $700. No more gold, no more casting, no more technicians who you just press a button and the machine does it.
We need something in endo like this.
You have. They're producing them in the grad programs where they don't want to think or anything. They just want to whack and pack. I'm telling you, it has to change. No, I'm not kidding. Some of you are recent grads here, right? Those are the guys who are most pissed off at me. Those of you who have had some experience can laugh. The guys who are not laughing are the recent grads. They are like, but yeah, can't say it because I'm being recorded, but don't lie to me, I know the truth. Okay, but look at this patient, okay, and then this is not well done, because this is still one of our earlier cases. You look at the pink ceramics, it's not that nice. I'm going to show you some really gorgeous ceramics now that can be done, right? But look at it when the patient smiles. Now, where do I see things breaking down in this patient? It can be mechanical failure of the restoration. Am I concerned with that? No. Why? Because we are screw retaining these restorations. We just have to unscrew it. There's a provisional that goes to the patient before this. We make the patient sign off in a chart that we've given them back their provisionals. They bring the provisional, we exchange the restoration, and either we repair this or we make another one. So you have to understand that it's not just this, it's not that we hate teeth and we love implants. It's that treatment begins for us after we insert the restorations. After you have completed your endo, patient is out of pain, the lesion is healing up. That's the end of your association with the patient. So you have to understand that's the way restorative dentists think. So that's my job today. Gary said He wants all of you to understand how we think. Right? So I'm trying to explain that to you. If anything is unreasonable at any time, if somebody wants to object, let's have a discussion. Just don't throw things. Just have a discussion, okay? So here is another one. Patients never want to have their teeth extracted. Oh, I did this because the patient didn't want to have the tooth extracted, right? Okay, so let's look at this patient. I treated this patient. This is in my practice, okay? So this fixed partial denture is failing, right? We have an implant here, and I asked the patient, let's remove these two teeth because we can have this reconstructed with the implant supported restoration. The patient says, no, the problem is only with this tooth. I want to keep this tooth. So I said, I really don't recommend that because you've lost so many teeth. So that's why you have to ask, why is the patient here? This patient is losing teeth because she has periodontal disease, and it's not localized, it's generalized. So you always have to ask, why is the patient here? You have to have a diagnosis, and the diagnosis should not be necrotic pulp, tooth is not responding to a pulp test. That's not the diagnosis, but that's on your prescription form, right? The patient has some pain, there's a fistula. That shouldn't be that's the diagnosis of the tooth. I understand that that's your problem, that's not my problem. But you also have to understand some of my problem, is that what are you going to do with this tooth? So what Rick has shown, Rick's presentation was focused for endodontists. So most of the things that he showed were for one tooth. For one tooth, I can roll the dice. My patient can roll the dice, no problem. But this is a reconstruction of a segment. What do you think that this segment would cost a patient in private practice? I gotta eat, man. 5,000 or 6,000 is my lab fee. Are you joking? It's closer to 10 to 15 when you add in the implants, right? And so when you reconstruct this segment, you have to make it clear to the patient what the consequences are. Right? And that's really, the patient has a part to play in treatment planning, but that's where the risk benefit and cost benefit comes in. Right? So if you tell a patient, look, we removed this tooth and you don't have to, revisit the situation again. So a patient refuses, and true enough, the tooth fails, we take it off. And then what you're looking at there is a provisional cylinder. Now we have to go back. We have to make a provisional restoration. You can see that's the pontic. The tooth has been extracted. That's the pontic. We wait for healing, and then we complete the reconstruction. Same two implants. There are already two implants in the sexton. Two implants can support 3 units, right? But it can also support 4 units. It can also support 5 units. So the question that we are asking is, what is this tooth that has already some attachment loss in a periodontally susceptible patient, what does it contribute to the reconstruction? Okay, so unfortunately, this patient had to pay twice for the reconstruction. Is there something we can salvage from the previous reconstruction? Yes, just the framework, because this was a metal ceramic restoration, just the framework of the previous restoration. She had the old provisional, we brought the provisional in, we added a pontic. On the framework, we had to take the framework from her, strip the porcelain, solder on a pontic, and then remake a restoration. It was less expensive, but still a pretty penny for the patient, and all the time. And so I'm going to show you case after case after case, but I hate to say this, but more often than not, on these larger reconstructions, when we bet on the tooth, we lose. So part of that is the endo wasn't as conservative as before. Part of that is that age is not kind to any of us. And when you have these patients that get old enough, the ecology of the mouth changes. The number of xerogenic medications that they take increases. And you're just going to get decay. So I'm just going to show you. Look at this particular patient. all those implants in there, what is the purpose of this tooth? How does that tooth help the reconstruction? What is the risk benefit of keeping that tooth? If we keep this tooth, we can put a crown on it, but if you put a crown on it and something happens to the tooth, the patient already has a history of tooth loss. What happens to the tooth? Right? So in this particular situation, I'll tell you what the purpose of the tooth is in the short term. The purpose of the tooth in the short term is it helps to stabilize the surgical and radiographic guide. No, I'm serious. We keep teeth to support that, and once the implants integrate, we remove the tooth.
See, Winston, this is a problem in our specialty because we have a whole world view that any tooth that can be saved should be saved, because no one is thinking strategically about treatment planning. They're just thinking tactically, but not strategically.
That's right. That's why that what Gary says is exactly right, and that's why I'm just trying to explain to you what our perspective is and how it impacts the patient. That example that Rick showed of the $60,000 reconstruction, if I was the one providing that reconstruction and one lateral broke in between two implants, I would have to eat it. If it was within a year, I would have to eat it. That means I would have to remake either one of the anterior or posterior segment. I would have to extract the lateral. I would have to put a provisional in there and nurse it along for a good 3-4 months until that socket organized, and then go back and reconstruct the segment with a new restoration. And that would probably mean I did that reconstruction for free. Okay, so that's the situation. So I'm a full-time member, a faculty member at USC, but I make most of my money in my day and a half of private practice. Right? A lot of people in universities, they live at the university in the ivory tower. They're not out in the community. They're working the school faculty practice. That's not the way it is at our school. We all have our private practice. They're all extramural practices. You live and die by your practice. You're at school for fun. Yeah.
I noticed in that case you just quoted that there was no post-buildup in that case.
A post doesn't strengthen a tooth. So, I mean, if I have enough retention, I don't know what the feeling for fiber posts is, but fiber posts are pretty much worthless. If you look at Ferrari studies, they go up to 7 years, but there's no more than 7 years after that. If you think about a fiber post bonded with resin, you have a thin layer of resin, right? And your fiber post, and you have flexion. Everybody agrees with that. And what happens when that resin, which is brittle, breaks down? Just think about it. So we don't use fiber posts. I don't use fiber posts. I don't know, that again might irritate somebody here, but I'm not an expert on that subject, but if you want, you can bring Dr. Donovan, or you can bring one of my former residents, Mario Bresciano. You heard Mario present about fiber posts, yeah. They are experts on the subject, right? And they've done quite a bit of stuff they can add to your discussion. That's not my area of expertise.
I think post or no post, the tooth brings nothing to the treatment.
Yes, exactly. In this particular case, the tooth brings nothing to the treatment plan. That's the point that I'm trying to make. Okay.
In terms of what Gary says, and endodontics, what he was saying, as our specialty doesn't see, is something that you teach about, which is really profound. You got to work in segments.
Yes. A reconstruction. Well, a reconstruction is anytime you restore a segment, you got to look at the whole area to think about what's happening in the area, right? You don't want to just think about a tooth. You don't want to think about a tooth. You want to think about, why am I doing the endo? I got referred a patient. I didn't put it up here, but I got referred a patient by an endodontist where he had done like 12 endodontic therapies on a patient who was a meth addict, is a meth mouth patient. I would have extracted everything. I mean, it was crazy. But instead of getting a treatment plan ahead of time, just did all the endo. I mean, that's just foolish. Yes, sir.
Kind of an old school question, but the buccal plate and the labial mucosa is really thin on that cuspid. If you take the cuspid out, how do you keep that area from collapsing and maintaining it from an aesthetic perspective?
I'm so happy that it collapsed. Because everything around there is already resolved. Everything is already resolved. This thing would be an outlier. And on the mandible, I actually don't care about aesthetics. But I'll show you some maxillary cases. Because you have to understand, okay, let me ask something another way. I have this argument with periodontists also. Is there anything you can do that is going to prevent resorption? Any percent. And you expect whatever you put in the socket to be bone. Let me follow up. Okay, well, I want to see the evidence. And you cannot use implant integration as a proxy. You cannot use implant integration as a proxy to success of your bone graft, because a part of the implant is past the socket, and I think a lot of your so-called peri-implantitis is graft failure. You put something in the socket, even if you think it becomes bone, when does it become bone? When you're ready to place your implant? When? Can it become bone next to an implant when you're reducing the blood supply now? One side is dead, the other side is your bone. You take a tooth out because there's some infection in there. Answer all those questions and tell me that putting something in a socket that's a foreign body is not a risk. If you say, I accept the risk, we can be friends. Otherwise, we can't be friends. Yes. Putting an immediate implant in is a risk not to the integration of the implant, but it is a risk to where the soft tissue ends up. So if you're putting in an anesthetic area, not a problem. If you're putting a single implant in, not a problem. If you're putting a multiple implants in an aesthetic area, it's foolish. And anyway, that's not the subject. So I understand you place implants, but that's not the subject now. And again, when endodontists go to other endodontists to learn to place implants, let's put a big question mark there, because I'm going to have an endo course. And you need to come to me to learn to do endo. Yeah, Cronin says 2 weeks, right? Come on, I mean, get real. Why don't you go to the best people to learn about implants if you want to place implants? I mean, get real. I'm sorry, I know I'm offending somebody, but I've been known to do that. Yes?
It was a quick question. I'm back in Ireland just a bit over a year now. I was working with the periodontist for a while.
Ireland has very nice golf courses. I've been to the Ring of Kerry twice.
But the problem I ran into was, after hearing Rick over the last few years, is pastoral was difficult because I'm condemning so many teeth, or at least I'm being very down on a lot of teeth, and patients are kind of, okay, I'll maybe have this taken out. A number of patients would come with very poor historians. They said, I've had issues with implants, I've had to have implants taken out, I can't remember who did it,
Yes.
it's a lot of years ago. The periodontists I was working with would say, it'll be okay. So I found myself in a bind because I was saying, I don't think you should be spending any more money on this tooth. Periodontists try to reassure the patient, do you have much of a problem with patients who, or do you you're not in the business of having to convince patients?
No, I am in the business of convincing patients. I am. I mean, this gentleman is saying that, some periodontists want to hold on to teeth. So you have to know the team of people you're working with. And I have some examples up here I'm going to show you, all right? You're going to have periodontists who are cutters, right? Those are the guys that want to do surgery and place. You're going to have periodontists who like to just massage the gums and maintain teeth. So depending on which patient or what is going to do with the patient, you have to send it to the particular person because they have different philosophical bents, right? And as far as me, L.D. Pankey, very famous old-time guy from the Pankey Institute, his most famous statement for me, if patients knew what you knew, they would want what you want. So if you can explain yourself to the patient, why do you want to do this? Mrs. Jones, this is what I've seen in my experience, and you know what I say really doesn't matter. There have been these studies done with thousands of people, by people much more skillful than me, and here is the information, right? Here is the information. And he said, if we still want to do what you've done, I will have to comply, but I am not going to take any responsibility. The responsibility is yours. And here will be the remedy if something goes wrong as we predict. Right? I don't try to convince. I tell them exactly what the story is. And in fact, in my program, we have this book of stories that they tell patients. Right? And I say, you have to practice saying these things, look them right in the eye and be convincing. Yes?
It's one thing to convince the patient, but then how do you convince your main referral source? Say a restorative dentist is sending these patients to you. They have already treatment planned the patient. In a case like this, they have opted to keep the tooth. Now, are you going to call the person back and say...
No. Listen. If I, as the restorative dentist, so let's be clear. If you're working with a good set of restorative dentists and they include you in the treatment planning, and I say, I want to have this done, and you as a specialist understand that, but you should only be commenting on the risk-benefit of the endo. As far as the segment of the reconstruction or the reconstruction, the aesthetic benefit of keeping a tooth, that's my problem. I think what Rick is alluding to is if you are an endodontist that wants to raise the level of your referral groups, the answer to that is you have to educate them. Rick has a study club, and I've been invited twice to that study club, not to speak to Rick, but to speak to his referrals about how I treatment plan. Rick, the last time was you weren't there, you were traveling, was a waste of time because they all agreed with me. The first time there was a disagreement. The second time, I think they felt that they wasted their time. So what Rick has done is he's educated his referrals. So if you want to have the type of practice that Rick has, my advice is you educate your referrals. Right? You have a study club, and part of that is to tell them what a great endodontist you are. But the other part is to maybe change the way that they think. You know, the periodontists are way ahead of you guys in that game. Right? The periodontists, a lot of them, you have an A, B, C referrer, right? A is the one that you're the only guy that does perio for them. So I'm using them as an example. Every time they have a periodontal or implant, A. You're the A guy. The B guy distributes the patients. The C guy, you see the patient once a year or only if his wife, right? Or his daughter, like the ones I referred to Rick. So if you run a practice, you don't want to just live with the A, B, C. You want to be really nice to the A guys. You want to make the B guys A, and you want to try and make some of the C guys B. And as your practice matures, you kick all the guys who are the C referrers out. You just want to deal with the A's and B's. Anytime one of the A guys is going to retire, you panic. Right? I mean, but then you'll have a great practice. So if you're not doing that, you got to learn from the periodontist.
Winston, before you move on from that case, I just want to make sure I'm understanding. You asked the question, what does a tooth add to the overall case?
Yes.
And in this case, you have this tooth there, and I thought you were making a case for why not take that standing and cusp it.
It's out.
It's out. Okay.
It's out.
So in that case, that would be a single tooth. You have restored with implants on either side. Is that not a roll the dice single tooth replacement, or why isn't it?
It's because it can't fail by itself. That's why it's not roll the dice. If it fails by itself, it impacts my reconstruction. Actually, it impacts the patient's reconstruction.
Right. If you were to have kept that tooth,
Yes.
and you restored implants on either side, and it failed later,
Yes.
what would you do?
It would be whatever the patient wants. Most likely, it would be cantilevering from the posterior unit, but then there would be 1, 2, 3, 4, 5 units. Or you could cantilever posteriorly, it'll be 1, 2, 3, 4, 5 units. That's a pretty penny. Or you can place another implant in there, and then you have to decide whether you're going to immediately load or you're going to make a provisional, which is a 4 or 5 unit provisional unless the patient has kept the provisional. And this restoration wouldn't be in this arch form. It'll come all the way here and then this would be out here because of the position of the tooth. Because everything else has resorbed.
So you weigh those two options and decided in this case it's better to take the tooth out.
Yes.
It gets a little bit into the question of what is there that you can place and what can you do to keep from having resorption?
I don't care if I have resorption. I thought I answered that.
What comes to my mind is don't extract the tooth. Now, I'm not arguing.
No. In this particular situation where aesthetics is not a concern, I am not being facetious when I say don't care. I truly don't care. On the maxilla, I might do everything I can to keep a compromised tooth, and I have examples coming up for that. Maxilla on a high lip line patient, a very compromised tooth I will hold on to. Yes?
Quick question. I'm a little confused on some of the prosthetics. So it's in the upper right, I see 3 screw holes on that, and everything else is 4. Something like, what's the order of the timeline on the prosthetic?
When was this reconstructed?
So it's 4 implants, 4, but in the upper right, there's 3.
Oh, one of the implants was just put to sleep. We didn't use it. This was done at the university. When these residents raise a flap, it's like a machine gun. They want to fire in as many implants as they can. Okay, there's something called a maximum resident benefit on some of these things. Okay, but this wouldn't happen in practice. And also, these are very old. I'm just showing you historical stuff. And so there are more implants in there than we know that we need today. Okay, so today we are placing many fewer implants. We're also placing shorter implants. We're not placing implants as long as possible anymore. Right? We're also placing shorter implants because there's no benefit to really long implants. No point taking any risk. Yes?
Well, I tell you, I think you hit on a problem that I see in my area because I work with George. And we have problems with periodontists that we've asked them. We think this tooth should be removed and an implant placed, and they don't want to do that. They want to try to save the tooth, and we go through this whole going round and round in circles, and finally, the periodontist ends up being the person that commands what is being done. And,
not on my team.
Yeah, well, and I think the way implants and in preparation for implants, placing grafting material in, I think that's why their periodontists are shying away from doing implants like that. That's what I see. And they're all putting the non-autogenous materials in there. Is that changing? Is that going to change as far as how?
No, I don't think so. Right now, unfortunately, there have been many generations of of surgeons who have never treated patients without using all these grafting materials. So they culturally cannot believe that doing nothing works, except the people trained at USC. So they truly believe that if you take a tooth out and don't put anything in the socket, that it is malpractice. So at one of the meetings, I was presenting right after some guy who actually said that. And it was about single teeth, so I went up there, showed like 15 or 20 single tooth treatments, and preceding every case, I said, this is malpractice, showed the case, and next one I said, this is also malpractice, I showed the case, and I said, you know, we are just propagators of malpractice at USC. What can I say? So there are people who truly believe that. I think they're not evil people, but that's the only thing they know. So, you know, I mean, I don't know what else to say, but okay, anyway, let me go ahead because we're very, very early into the presentation. Yes. No, there are times when we do grafts, they're autogenous grafts, they're block, you know, they're block grafts, but not in the socket. Not in the socket. If we're going to put a pontic in there, a pontic, and we want to keep a dimension for the pontic, I think we may do that. Very rarely, but we have done that before in the pontic side. But as far as a ridge deformity or something, most of the time the safest way to do it, if it was me or my family or one of you who came to see me, even if there's a deformity, if there's bone to place an implant, we'll place a bone and then we'll do a connective tissue graft. They're very stable and it's very safe. Then we can get an aesthetic result. I just don't want to take any risks. So the issue is that some people don't believe that putting something in a socket that you're not sure what happens, right, except you feel the force, is not a risk. If somebody tells me I accept the risk, it seems to work for me, yeah, go ahead. But then you have to know what you're putting in there, how it transforms to bone, and when it transforms to bone. And when, that's the key thing. When is the maturity of the site? Because we can cut everyone of here in the room and all of us will heal at a different time. Can we agree on that we all heal differently? So how do you predict your patients? 4 months is the magic number? Or is it 3.5 months? I'm going to San Diego for TDO, so this patient is going to get the implant before I leave so they can heal while I'm away. Is that reasonable? 3.5 months? How did they come up in the early Brandemark protocols when nobody knew what they were doing to uncover the implants at 6 months? This was 50 years ago. How did they do that? This is placed into host bone, by the way, 6 months ago. It was arbitrary because they knew that for implant to reach steady state of osseointegration would take 2 years. So they decided 6 months is stable enough. It was arbitrary. So because they didn't know, they just figured, 6 months is pretty safe. Since then, we've shortened it to 4 months over time. Is that good? I don't know. Some people say 6 weeks. You get callus formation in 6 weeks, so 6 months is good enough. You want to take the risk? So we view implants to be in there for the long haul. Okay, I can't say lifetime, but I would say the long haul because the early group of Brandemark implants, they've been reported on for 45 years, and they have over 80% of the implants still supporting restorations on the remaining patients that are alive, because most of those patients have moved on to the next world with their implants. 45 years, over 80% of these implants that were only And they only had implants that were 7 and 10 millimeters long, way back then. So when we place implants, I don't know what the big hurry is. Because, I just don't want to take risks. I'm risk averse. Do you know why I'm risk averse? Listen to this. I have 6 residents a year. Each of them has to complete 6 reconstructions. That's more than any program in the country. 6 full mouth reconstructions. Every year that graduates, I have 36 reconstructions to take care of. You know what a nightmare that is? I'm very risk averse, and we train the residents the same way. Whose phone number do they have when these guys all go off to their practices? My phone number. Since 1986 to now, how many implants have we floating out there from USC? 20,000. 20,000. Guess who has to deal with them? Okay, so if you come to our program and meet our residents and ask them, how many repairs or, when things come back, have problems with the implants? With the implants, I have them documented in my computer for progressive bone loss, less than 10 patients. How many have mechanical problems? Oh, plenty. Broken screws, broken restorations. How many of them have misdiagnosis, meaning we missed the boat? Quite a large number. We're becoming better and better at that because I don't want to have problems. It's all about my self-preservation. Don't care about anything else. But when you have to deal with a reconstruction which you did not do, and these are complex reconstructions, it's a very difficult problem. You have to learn all about the patient again. What happened? How did this patient first show up in our program? What was the patient's problem? Because you just can't look in the mouth and say, oh, this is broken, let's fix this. Because they'll be back in another 3 months. You have to address the problem comprehensively. That's what I'm trying to get through to everybody. You want to ask a series of questions, and the more experienced you are, the more people you talk to, your series of questions will become longer and longer. The one with the most questions is the winner. So learn to ask the question, even in our literature reviews. In our literature review, which are topical, right? I set them up. It's always, what is the question? Because our literature reviews for controversial things show both sides of it. They don't just talk about one side of the story, they show both sides of it. And we tell them, listen, this isn't resolved yet, so you guys got to keep looking. But this is the question. This is the question. So I don't know about any of you, but we don't think, there are a lot of things we don't have the answer, but for the specific patient, if you ask enough questions, I think you arrive at a reasonable treatment plan. Okay, you arrive at a reasonable treatment. Anyway, so without taking out that tooth, you will never get such easy alignment and everything of your restoration, right? So, and I have no doubt that their restoration is going to last. Okay, look at this. We have this tooth here. We have 3 implants. Certainly don't need 3 implants. There's too many, and this one is probably going to get in the way because you might lose bone in between these two. But anyway, do you want this tooth to maintain that buccal volume for you? Everything is already receded. Why do you want that? Right? So we took it out. And what happens? It recedes. It's a pontic. Right? And that's the restoration. Is it perfect? No. But anytime you remove more than one tooth that are adjacent to each other, you are going to have the soft tissues flatten out. So for all the grafters that are in the room and all the CE that you guys go to, anytime they show you a super duper technique on one missing tooth, tell them, can you show us a couple of multiple missing tooth cases where you preserve all the soft tissue structures? Nobody will show them to you. Oh, I have them in another presentation. I didn't bring them. Well, I will tell you, I have all my presentations here, and the cloud. So anything that I say I have, I can dig up. That's the truth. And that's the truth for everybody, by the way, if they want it to be. Because it's so easy now. You have all the images. It's not like when we used to use carousels and slides anymore. Okay, so look at this. This is treatment planning today, right? Even though this is a very old case. We place the implant here and we place the implant here. We kept this tooth and this tooth to hold the fixed provisional in transition, right? Because the patient is going from one point to another. At the end of implant integration, we extracted the good tooth. The other tooth had subgingival decay. We're doing a forced eruption here behind the pontic. And then we restored that tooth as a single tooth. Sorry, you can't see that. But we have enough tissue there. That's the post. And then these two, that's a pontic now, right? It's easy to control the aesthetics around the pontic. And what you see is we have just a single crown there, implant, pontic, pontic. So because that tooth was in between, we didn't need it. We removed it. So counterintuitively, that canine had a nice long root. There was some decay there, but we can deal with that. We just erupted the tooth, did the endo, retreated, put a crown on it. Right? So I don't think we're frivolous in the way we remove teeth, but let me show you some more reconstructions and our experiences. Right? Let me just show you this. This is a patient that came. If you got to start looking at these patients like this, even before you put the rubber dam on or your assistant puts the rubber dam on. I know how you guys work. You look at the prescription, you tell the assistant, put a rubber dam on tooth number 3, then you go and check your stock market. You guys have all the money. The prosthodontists have no money. You should see our lab bills. Okay? So CAD-CAM has really helped us reduce our lab bills, but you guys don't have to worry about that. Okay? So, but you got to start looking. This is the patient in occlusion. This is the patient at rest. Look at the change in vertical dimension. Look at the lip posture. Look at the commissures. You got to start looking and noticing those things, right? On the profile, same thing, right? So this is our patient, right? And then you can see that this is her tooth display. It's actually right into her lip, not really good. And when you look in the mouth, you see 100% overlap of the anterior teeth. Okay, to us as a restorative person, that's a huge problem. You know, there's something serious going on here. And now we're looking at that, and then that's the amount of separation when you finally can get her somewhat edge to edge, right? So then you look in the mouth. On the maxilla, there's a tissue bar that's fractured, right? And it's attached to those posterior units. And these mandibular anterior teeth seem to have super erupted significantly, right? Then we look on the maxilla, and then you see a partial denture that's integrated with the fixed work. And those of you who have done restorative dentistry before, like Glenn and like Rick, they say, wow, that's pretty good, because this is one of the hardest things to do in restorative dentistry, because you have to plan. I have to prep the tooth a certain way, I have to make space for the rest, and then I have to make the crown a certain way, and then I'm going to integrate the partial to the crown, right? And that's very difficult stuff to do. And so, and on the mandible, that's what it looks like. Now, when you look at the radiograph, the question is, why is the patient here? Patient doesn't care about her vertical overlap or anything. There's no patient is going to come and say, oh, look at my mandibular teeth, they're super erupted. That's not why she's here. The patient is here because on this particular subperiosteal implant, it's compressing the nerve. The resorption continues under the subperiosteal, and she is in pain. We have to remove that, right? And then you look on the other side, there's a blade implant, and there's infection everywhere. So those are the old-time implants that are there. Now, here is when it gets very difficult. We have to treat the mandible, and that tissue bar fractured, so we're going to put some implants on the maxilla and make a tissue bar on implants and not connect it to teeth, because as Rick said, in the new way that we're doing reconstructions, we don't want to connect things. We want everything to fail discreetly. We don't want everything, if we don't want one thing to cause a cascade and have everything else to fail, right? So we want to do things discreetly, but on the mandible, because this is already compressing the nerve, if we remove this and we remove this, where's the bone to place the implants? Or you're going to restore this patient with a RPD. By the way, do you know what the definition of a removable partial denture is? A partial denture is a device for losing one's teeth slowly, painfully, and expensively. I have run the partial denture literature review at USC for 25 years. Nobody knows that body of literature better than me. I can debate anybody. Everything you learn in school is all horseshit about partial dentures. They don't work. They change the ecology of the mouth, and when they're on mucosa, they give you zero support. Zero. Okay? Think long and hard before you put a partial denture in somebody's mouth. So, partial denture is not an option for this patient. So, where is the bone to place the implant on the mandible? In the anterior. What is the prognosis of those teeth? Good. Only poor because they met me. No, seriously. The prognosis of those teeth is good. Now, here is where it gets very uncomfortable for everybody. Now, we're not talking about a decision between a so-so tooth and an implant, or how you can make the so-so tooth better, or do as little damage as you can to the tooth that needs to be treated. Now we are talking about extracting teeth with a good prognosis. So now people get uncomfortable. How do you feel about that? Tooth is 100% integrated in the jaw. You extract a tooth to place an implant. You can look at different analysis, but there's a 5% chance that the implant does not integrate. So, and that's modified by the patient's health history, right? Diabetics, smokers, anybody that's been irradiated, all those things go down. So you have to think carefully before you do that. But I will tell you that we do it pretty often. So for this particular patient, that blade is coming out, right? I don't think anybody would object to that. Look at the radiolucency around it and how it's really affected the tooth. In the old days, you always connect teeth to implants because after like 2 years, the tooth is supporting the implant, right? But those are the old days. This is a subperiosteal. You can see it sinking into the bone. It's right on top of the mandibular nerve now. It's compressing the nerve. It's got to come out. And this is the cast of the patient. You can see the super eruption and the rotation, right? So, whenever we get a chance to take pictures like this, we always take pictures because there's so much effort to get here, even though we don't like to do it. Okay, so we don't do this kind of stuff anymore, but it's pretty sophisticated dentistry. So whoever treated this patient was trying to do his best, but those were the only tools that he or she had, right? So we use the same framework. We replace the teeth, as you can see, and that's just a try-in. So the patient looks okay, and then now we're treating the mandible. We're going to remove the infected implants, and then with a surgical guide, we're going to remove the teeth, and we're going to remove a chunk of bone because we need the interocclusal space. So we were taught, right, when we were in dental school, when you extract a tooth, be very careful, preserve every fragment. Now we're not just removing teeth, we are resecting all the way down to the apices of the teeth. Okay, so we're resecting bone, and we're placing implants, as you can see, right? Interforamina, you can see that there was no bone at all on this side, right? And then we place some implants on the maxilla. And on the maxilla, we're going to put a tissue bar and an overdenture so you can see that they're not at all related to the teeth. And then we're taking our impressions. Don't worry about this. These are technical things. And then we're just doing a couple of procedures. This is so old, you can see that we're using still a cast gold bar, right? Today we're using titanium, much easier to manage. We can do a couple of clicks on the computer and we can get a nice framework. This is gold, we are casting, very difficult to control the distortion. And that amount of gold now can pay for a couple of house payments, but we're not using that anymore. But not Gary's house. For Gary's house, you can't make the payment. For a poor prosthodontist house, you can make a few payments, but not the rich endodontist. So this is the restoration that we've completed, right? And again, this is early on, so we are placing more implants than we need. But these implants are so strong that we can have a cantilever posteriorly. Can't do that to teeth, right? Everybody knows if you cantilever on endodontically treated teeth, it condemns the tooth. But you can do it on implants. And on the maxilla, which is what I want you to pay attention to, there are these crowns which, although well made, were over contoured, and the tissues really didn't look very good at all. So we clean them up, right? Clean them up, reprep the teeth, and get ready to make impressions. And we use this particular case to do a case presentation, right? So these are the provisionals, and we're taking impressions. So this is Mark Alexander. He's practicing up in Santa Barbara. This got published in 1998, but probably the case was finished maybe about 1995 or thereabouts. And you can see that we are using a different impression technique, just as a mixture for teeth and implants, a little bit, makes life a little bit easier. We can take the implants, impressions segmentally. We use different color impression material. But because we use it in a presentation, you can be sure that we recorded very, very clear margins on the preps, right? By the way, Rick, I wish you work near me because I don't like to prep teeth anymore, and I would refer teeth that didn't need endo to you. I would say, Rick, I'll pay you for the endo, just prep the teeth and put the cord in, because I mean, that's a good service. That's a great service. So anyway, so we made sure that we got a good impression, and the restorations, I can promise you, are well-fitting. Okay, so this is our reconstruction of the maxilla, no longer just resting on connecting the teeth, but on a tissue bar. This is a completed maxilla and mandible, as you can see. And so this is how the patient finishes off. Okay, this is in 1995 or so, right? This is our patient. She, you know, in all the pictures here, she was smiling, but she was a miserable patient. But anyway. Anyway, so just to remind you, this is how we finished off. And the question now is, what does the patient look like 15 years later? 15 years later, you can see there's some inflammation here. There's some wear on the tissue bar. And what do we see here? So initially the crowns didn't fit that well and there was no disease, right? But why are we seeing this now? Why are we seeing this now? Patient is getting older, more medications, and one of the major things that happened to her is that her husband is diabetic and he got a bleed into the eye and became blind. So she spends all her time taking care of him. And she just can't take care of herself that well. And she's on a bunch of medications and everything dries up. And so she had decay. So, but the next question is, how do the implants look? How do the implants look? Now, in 1995, that's like 20 years ago, I would not have extracted the teeth that I'm showing you have decay. I think we treated the patient appropriately. But just to show you what happens to these patients and how implants are resistant to decay. So most of you don't have to deal with it, but one of the biggest problems of the elderly patients is root caries. You really can't fight it sometimes. You can't fight it. It's a difficult issue to deal with, okay? But look at the implants, okay? So let me show you another patient. So when you look at this patient, all of you already know the treatment plan. Look at the amount of resorption back here, even without the radiograph. And what is the prognosis of these teeth? What is the prognosis of these teeth? The prognosis of these teeth is good until they met me. But that is the only place we have to place implants. So let's look at our patient, right? What happens? This patient is a faculty member. This is the kind of patient at the university, not the dentist. This is the kind of patient that when you see them in the cafeteria, you don't know whether to turn away or to say hello. You know, because when they start pointing to their mouth, you're in trouble. Okay? But look at that. All right? No bone, no bone. And amongst all this horrible stuff, she went to see somebody and they placed an implant up there. What an idiot. That's called no treatment planning. Right? That's called no treatment planning. And that's why treatment planning is so important. Not only that, after a while, there was a fistula. We thought there was a problem with the tooth, but it was the implant, and the implant had to be removed. And you can see the implant was damaged. It was removed. And at that time, this was also about 20 years ago, we decided, we already prepped this tooth. Let's just make a fixed partial denture. So what does that look like in 20 years? Let's look. So there we have, all right? So this is the restoration, right? I think that everything was done well. This is provisionals. In this area, we decided, this is the premolar area, we decided to place 2 implants. We didn't want to have a fixed partial denture, right? So we placed 2 implants, as you can see, with the surgical guide. You can see if you know what you're doing, you can put everything exactly where you need to do it. And fortunately, we have really good surgeons working around us. And so 2 implants were placed, and a bunch of implants were placed on the mandible after those teeth were extracted. And then we go back and reconstruct the patient. Okay, that's the same cast gold bar. That's how you can date these things. They're pretty old cases, maybe 20 years old. This is just metal ceramics on the maxilla. That's a FPD here. And then we deliver, right? And this is the patient as she was completed, right? She has a posterior support back. She has all the teeth. She's very happy, right? Looks good. I think it was a great result. So the patient is very happy, tells all her colleagues in the faculty how great the dental school is. This is her old picture. This is her. She's pretty happy. And then this is the before and after, right? So this is our patient about 20 years later. What happened to that FPD up here? Is it tooth supported anymore? These are the implants that were placed posteriorly. They still look good, see? Now we've connected them to implants on the anterior. And the question is, should we just have placed an implant up there instead of an FPD? If we did, she wouldn't have to go back in for surgery again, even if she had a problem with either of the adjacent teeth. We could have just connected across. Instead of that, we had to open her up again and do another surgery. And what Rick spoke about when Max Anderson looked at the Delta Dental West Coast database to look at the number of procedures adjacent to a pontic compared to the number of procedures adjacent to a tooth, I think really tells us something, right? Because if you speak to any restorative dentist that's honest, right, they will tell you that they check in the margins of individual crowns with the sharpest probe they have. But when it comes to a FPD, we use the ball burnisher. Because it is impossible to have as good a fit for one tooth as multiple teeth. Because in restorative dentistry, before CAD/CAM, half the things expand and half the things contract. And you can never compensate for the expansion and contraction of all those materials. So basically, fixed partial dentures don't fit. Not only that, you're putting more forces on the teeth, right? And then they have differential retention. So decementation is very common, which I will address. And then look at the mandible. These are abutments, by the way. This is the platform of the implant. And this little crater here, that's the extent of bone loss that you have. This is 20 years. This is 20 years. It is not atypical. It is not atypical. But remember, we didn't graft, we didn't immediately load, we didn't put anything in the socket, we screw retained so there's no cement in there. So think about it. So when you compare and somebody shows up, look at this thing, it has bone loss around it. the first question should be, do you know the history of the implant? Do you know who placed the implant? Do you know whether it was loaded? Do you know if there was a graft material around the implant? And when you can answer all those questions, then it's more like a tooth. Because teeth don't erupt with defects and bone graft around them. They erupt into bone mostly. Right? So I know there are people in this room who are grafters. Sorry, but we have a different experience, is all I can say. And it's not just me. It's the experience of many generations of residents. It's just that I'm collecting the stuff. And so you can see what happens. And so we have these recalls of these patients that we are seeing, all right? So look at, this is another patient. This is another patient that I made a mistake. Gary, I treated this patient with Brent Bayek. And Brent is an excellent, excellent prosthodontist, okay? He's up in Victoria, BC. And you can see this is a patient that shows up. This is the educated lady. She's a vet. Very nice lady. And so we went ahead and did everything we were supposed to do to work her up. I'm not going to talk about the technical part of our treatment planning. I just want you to look at the thing that we missed is that she has a lot of restorative dentistry and she is failing. The question is always, why is the patient here? This patient is here because she's missing some teeth, and she's missing teeth because she's very prone to decay because she's not that old. Saliva flow is normal. We just check, you always check saliva flow, have them chew on paraffin and spit out, and you can look at the volume of saliva. Everything looks okay, but for some reason she's very decay prone. Her oral hygiene is acceptable. It's not horrible. And so look at that. We do all this fancy stuff, right? Pantograph and so on. And then look at the preparations, nice and clean. In these days, we weren't doing that many bonded restorations, so unfortunately, we're removing so much tooth structure. We remove a lot less tooth structure now. The future of dentistry and care for the patients, for missing teeth is going to be implants, and for teeth that remain is going to be bonded restorations, right? It's going to be bonded restorations. Are they going to be as durable as PFM or gold? No. But I'd rather the restoration break than the tooth break. And we tell that to the patient. They say, how long will the restoration last? I just look them in the eye and say, is the tooth more important or the restoration? You answer that and then I'll answer you. Right? And most of them will say the tooth, of course. And so, will I have to pay again? Of course you have to pay again. I got to eat, right? So, anyway, so there you have it. This is the patient completed, right? This is the patient completed, we move on. And now we're going to look at radiographs year after year. Look at that. What happened to that maxillary segment there? Do you remember? There was a FPD, there was some endodontally treated teeth. We put another FPD on, it failed, right? And again, it's not the endo that fails, right? It's the tooth that fails. It's the tooth that fails. And then we made some mistakes down here. We kept some teeth that we shouldn't have, right? And you're going to see what happens. See? Fail. Teeth fractured, right? And just look at this. Look at how it progresses, right? Look at how it progresses. These teeth are gone. And now we're going to place implants across the arch, right? And so this poor patient has been in and out, in and out, in and out, because we made the mistake. So we have a history of this. And so when we make our decisions now, we're a lot more definitive about the way we make our decisions. Look at the mandible. Look at the number of implants that were placed. With that number of implants, you don't need anything else. Look at that. Right? Now, why did that happen? Could be any one of a number of reasons, but that's not the question. The question is, when you see these patients that are breaking down because of decay, right? Let's say the first time we did it, we made a mistake. When the patient comes back the second time, and some teeth are failing, and we are re-evaluating. At that time, we have to figure out, to quote John Coyce, which is a friend of ours, teeth are not for everybody. It's time to remove them. Is that being frivolous or cavalier? No, I don't think so, because the number of procedures and surgeries that this patient went through are no fun for anybody. And you know what? She was so nice about it. You know, at least if she was a bit nasty, we'd take great delight in jabbing her with a needle. But, you know, we feel bad. We feel bad, right? And so we finished the reconstruction, and then she fractures another tooth. So we should have actually just cleared it out. We should have just cleared it out, right? So let me show you this patient. Oh, this patient is my favorite. This is a patient that I treated in the grad program. This is the first reconstruction that I ever did as a dentist. In the days when I went through the grad program, we had a program director called Jack Preston. I don't know whether anybody here is old enough to know Jack Preston. He was one of the early people on aesthetics, right? And metal ceramics. So I decided to study under him. He was very, very good program director, but he wasn't anybody's friend. And the Canadian way to describe, any Canadians here? No? Oh yeah, okay, he'll understand this one. He says, his ring was so tight he couldn't fart. I learned that from a Canadian, but really an uptight guy. So, and we had to do all our own lab work, everything, all the way to porcelain. We don't do that anymore because there's no way we can do it as well as some of the ceramics now, but he thought that was something that we had to do. So we were baking porcelain. Every one of these restorations was made by me, no technician. There's nobody to blame but me, right? And in those days, in 1986, we just started using gloves. He refused to use gloves, right? So when you ask him to check something, you hand him an Explorer. He says, I have one on my own. And he pulls out this thing that is sharpened to 0.01 microns. And then he's checking, and you're just sweating because you spend so many hours on this thing, you don't want to do another one. So anyway, I get through it. I think I had to remake one or two of these things because Jack will never pass anybody. You always have to redo something. So I remade one or two of these things, and the patient was local, a very nice Japanese lady, very compliant, and she said, where are you going to practice? And I said, I'm going to practice in this area. And she says, oh, I live near there. So what every resident hates, I'm going to come to your practice. Oh my God, you know, why can't you just stay in school? It's not my problem. But truly, she was a very, 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 very nice patient. Is still with me. So 1990, no problems, right? And this is when I first finished my program. You feel like you know everything, and I'm so good. You know, everything I do is better than the other guy. I am so good, all right? I really, you know, 1997. Wow, nothing. Wow, you're so good. Anytime I have and I began to have some problems with my other cases, and I would say, a damn technician is just not as careful as I am, right? From 1997 on, every time I saw this patient, she had decay somewhere. She was on fluoride, she had electric toothbrush, she had water pick. She was very compliant. Reduced her interval with our hygienist where we put fluoride varnish to 3 months. She had no periodontal disease. She actually didn't even have decay. This was the way we used to treat patients with severe wear before. We don't do that anymore. We use bonded restorations, very much more conservative. But back in the day, we prepped teeth. Right? And every time she came, she had decay. So it went all the way till the year 2000, and I said, her name was Lily. I said, hey, Lily, I'm sorry. Let's not fight this anymore. I said, you're frustrated, I'm frustrated. You know, one tooth at a time needs to be treated. We chase the margin down. You have crown lengthening. I patch it with glass ionomer. then you have an endo, and then I put a new crown on it, and then we get decay around the margin. It's a no-win. So she said, okay, what do you suggest? I said, we're going to extract 4 teeth strategically, and we're going to place 4 implants in there. And we're just going to let the decay go. If any teeth fracture or you're in pain, we're just going to extract the teeth in between and we're going to connect. And she said, well, that's pretty radical, but if you think so, let's do that. Because she had been with me for 20 years, so she trusted me. So I said, okay. She said, okay, let's do that. So we placed those implants in there. She had 1 tooth needed to be extracted. We extracted another 3, and we placed 3 implants, right? And true enough, she had problem with one of these teeth. We extracted the 2 of them. You can see the provisional that I placed on the implants already has formed the soft tissue. So it's been in there for a long time. So all we did was we took an impression of that, made a provisional restoration, put it in there immediately after the extraction, left them in there, and then completed the restoration, right? So this is the definitive restoration in place after healing, right? And then you can see the decay on all the other teeth. And so the question, and so the story continues now, right? So the patient, you can see that she's zero stomach, by the way, so she cannot wear a removable partial denture. And that's secondary to age and the medication she's on, right? So now she's wearing, we placed some other implants, but you can see that it's extending now to the other side. And so you can see we're extracting these teeth now, placing more implants. And you can see this on the other side of the jaw, you can see the decay around the margins now, right? And eventually, we're connecting all the way across to the other side, and we are trying to salvage as much of what I have in the mouth as possible. You can see we have a metal connector there, so we're doing a post-ceramic solder. Those of you who have done restorative dentistry know that's one of the most exciting things to do. You put porcelain back in the oven to solder it to another unit. Everything can just explode on you, especially if it's already been in the mouth. But we're screw retaining everything, so we can remove things, and we're able to manage it, and eventually the whole arch is done, and we've added implants in there, right? But all this while, she has not had to wear a removable partial denture. So where is our patient today? 1986, 2010. And I'm telling you that it's not just about endo, or we don't want to send patients for endo. As Rick said, we don't care. We just want the reconstruction to be durable. We just want to be able to bail ourselves out of a problem when we have a problem. It's very difficult to do with teeth. It's usually not the endo that fails and you get a shot retreating it. Usually what happens is decay subgingival or fracture. And I don't think you all see enough of that, right? And if you practice next to me, wouldn't you, I mean, there are 2 ways you can look at it, right? Every time I have a tooth that I'm going to extract post-endo, I'll say, hey, come and take a look at the tooth. And there would be decay or fracture. It might really irritate you like crazy, right? It really may irritate you. But I think it would be better for the whole profession. Again, there's opportunity to do that in a school, but most of you are not taking advantage of that opportunity to learn. So we have these failure cases that we show during treatment planning. The endodontists are not there. Do you think it would be beneficial for them to see it? Again, it's not that I would have extracted those teeth back in 1986, even if I knew everything about implants now. But when the patient started getting decay that I couldn't stop, even with all the home care and professional care in the world, at that point, I should have decided I'm going to place implants strategically and move to an implant reconstruction. But I didn't do that. But guess what? I'm doing that now, and that's how I'm training the residents in my program. Now, you know, explain to you in that context, are we bad people? Are we anti-endo? We're not. We are pro-patient. Yes?
Does John Coyce have a similar mentality? We have a lot of general dentists in our city that have taken all his coursework.
Yes.
Does he have a similar take on things?
You know, I don't really know. I don't really know. Okay, John is a very good friend of mine. I think on many things we do agree. But if you know John well, then you know that one of his most famous statements is, "Because I say so." Right? But I don't do that. I present the issues. We look at the literature. We do some of the geriatric literature. We look at age change. We look at xerostomia and its impact on teeth. And I let the residents make up their mind. So John trains his people very well because he gives people a recipe. And I must say that it's a very safe recipe, and anybody that goes to his program that follows the recipe is going to take good care of their patients. Right? So I believe that he's got a very, very good series. But we don't want to produce that in our residency because we have 3 years, and what we want to do is impact the way people think. We want them to be critical thinkers when they leave and ask questions. Gary just came to our alumni symposium. Gary, they were all alumni presenters. Were any of them the same? None of them were the same. But we're very proud of them. They're all leaders wherever they go to. I don't want them to be clones of me. Were you at Colorado when I had an all-out yelling session with Jean-Pierre about peri-implantitis? This is one of my residents. We stood in front of our study club and we just had it out because he trained with Todd Berglund. He truly believes that peri-implantitis is a disease entity. And I said it's a disease entity sometimes. If I have time, I'm going to address that. Sometimes. Because, you know, it just may be a foreign body reaction. The implant is a foreign body. Right? So I think that John does think the same way in that as far as supporting units go and risk, after he does his risk-benefit assessment, a lot of teeth come out. But I don't know whether it's exactly in concert with what I'm thinking. Right? But I mean, it is. I mean,
He does cemented treatment, but retain the restoration.
I think he's going to change his mind because the amount of evidence now that is anti-cement is huge. I mean, I just finished a lit review with my grad students. There's like 3 or 4 pro-cement articles and there's like 60 anti-cement articles. They've looked at the biofilm of the cement, they've taken biopsies and did X-ray diffraction and showed that there are cement particles around the soft tissues. There are the endoscope study by Tom Wilson, that's the most well-known one. And then there are several centers in Germany by a guy called Korsch, K-O-R-S-C-H, where they actually physically remove all the restorations that they cemented. And they found cement under almost 80% of them. 80%, 80. And they've looked at now the biofilms that are on this cement, and the most aggressive ones are around resin cement. Guess what's the most common implant cement? Resin. Why? Because it's radiolucent and they don't want to see the problem. No, I'm serious about that. Yes?
I'm just curious, you had mentioned before that you can support a whole arch with 4 implants.
Well-distributed implants.
Okay, so with this gal, knowing that she had this decay that you didn't feel like you could stop, you could kind of see the writing on the wall.
Yes. That's how I would treat the patient. I would strategically place 4 implants.
So why did you not do that? Why is there
Because this was a transition over time, and it was earlier in my career, and it took a while. I mean, today that's how I would treatment plan this patient. And then to be honest, these were restorations that I made, so how can they fail? No, I mean, it's kind of a joke, but you have no idea as grad students how much we have invested on these damn things. But, and because I was such good friends with her, it was a little more difficult to make the decision. It was less separated, like a family. But if this was just any patient that I knew the history of and came into my practice, that would be the decision. I'm going to have 4 implants, well distributed. I'll put a fixed provisional in your mouth on some of the remaining teeth, and then everything else comes out. Yes?
What's your take on the all-on-4 concept with same-day restorations?
Okay, so I think it's a great business model. I think it's a great business model, and then if you have a hammer, everything looks like a nail. But it's a great business model, and they're making a lot of money. So let me ask you, do you think that immediately loading is a risk? And if you think that, if you believe me, and if you don't believe me and read the literature, do you think that an integrated implant could be a lifetime supporting unit? Most of the time, 80%, in 45 years, 80% of the time, right? I mean, it's only one study because they have the longest pool of patients, but 80% of the time, yes. So why do you want to take that risk? But that is their model because that's what they advertise with. And there's a company called Clear Choice that is their business model. It's $26,000 an arch. The business model is you place one arch in the morning and you restore one arch. So every day. So $26,000 a day times 5 times 52. Work it out. It's big numbers. And they use the restorative material is titanium and plastic. So there's no discussion about, what is the risk benefit? Do we do this? What is the diagnosis of the patient? It is, we can do a full arch on this patient. And Mrs. Jones, you can have it all in a day. Is there a place for it? Yes. Do we do that? Yes, when it's indicated. But I'll tell you, the indications are not that common for us. And for them to get consistent aesthetics, right? To eliminate the analysis of the smile, what do? They resect the junction of the prosthesis to the soft tissue above the lip. So if you have a mobile lip, they're going to resect more bone. Then they're just looking at the amount of bone from the nasal floor to wherever they resect for implants. The implants don't have to be very carefully placed because they use this pink prosthetic stuff that camouflages everything. So the surgeons have to be fast, but not good. And you don't have to think.
Is there a good body of literature that supports long-term outcomes on this?
Long-term outcome of the implants, there's quite a bit that shows that the implants will survive. But plastic was designed for complete dentures when your bite force is about 20% of natural dentition. And we know there are studies where we have implants that after 1 or 2 years, the bite force approaches 80 to 90% of that of natural dentition. So they have a ton of breakage of prosthesis, which is not disclosed to the patients when they walk in there. So they have constant resurfacing of the plastic. So we tend not to use that so much. We are using the high-strength ceramics. We are using metal ceramics. We use plastic on titanium once in a while. On the bars that we showed you up here, we put metal occlusals on the posterior just to help prevent wear, because plastic doesn't survive long in the mouth. But the implants, they survive. So so they are like a broken clock, right? Once in a while they tell the right time because they have the right indication. Meanwhile, they have a hammer. Everything looks like a nail. So does it work? Yes. Is it the best thing for the patient? Sometimes. And I hate to say this, some of them don't know when the right time is. What can I say? Right? And you know what? They don't want to treat anything but full arches because that's the biggest money maker for them, because they have a system and a protocol. They have a system and a protocol. They don't want to think. They want to be production line. Has anybody pulled out a calculator and found out what 26,000 times 5 times 50 is? That's a good business, and they have a whole chain of clinics all around the US, and they advertise a lot. They're a corporation, Clear Choice, right? Okay, so another patient. Just looking at this patient, you know she's on antidepressants. 2005, those of you not in Southern California don't understand this, but 60% of the patients that we see are antidepressants. They cannot have a bad day. They cannot feel any stress. They can't be miserable. Nothing can go wrong. So they take antidepressants, like candy. And they dry up the mouth. But look at that, 2006, right? There's some decay there. She's in for a reconstruction. She's already had the reconstruction done, unfortunately. So we place some implants in there, okay? Again, we decide that, well, on anterior, we're going to hold on to the teeth because, it's important for aesthetics and the papilla and everything. So we place a couple of implants back there. Patient is happy when she finishes. We only got her on a good day. And then, say again? It's a little white. Oh, that's what they want. That's what they want. All right? So the treatment is completed in 2007, right? Everything looks good. Everything is good, right? You call it toilet bowl white. Here you go. So just look at these two teeth and look at these teeth down here, right? So this is our patient when she's completed. I think everything looks okay. And this is our patient not too long later. So the question is, it's kind of stupid of us, right? Not to remove those teeth in retrospect. So that's why we're changing the way we think. And it's not just those teeth. We're going to look at the mandibular anterior teeth also, right? And mandibular anterior teeth, there's decay everywhere. Again, it's medication related. There's decay everywhere. Why didn't we take those teeth out earlier? Why didn't we redistribute those implants? So she's got 4 implants on the mandible back here, but now we're going to leave those intact and we're going to place some more implants on the anterior. Would anybody here, you can keep these teeth. You can. You can remove the crowns. You can do crown lengthening. Take a look at all the endo, make sure there's no problem. Anyone that you think is a problem, you can retreat because we're going to remove the restoration for you. But what is the risk benefit? So let me ask you again, are we bad people? Yes?
No, you're not bad. But can I ask a question? Suppose you have 100 patients.
Yes.
Exactly like this.
Yes.
But they're different age, different medication, different...
Of course they will all be treated differently. But on this patient, I'm talking about this patient, we have a history that we treated her once already, right? We already treated her once. She's on the medication. We couldn't control it. And so why would we make the same mistake again? Why would we go a second round? So if, I may have other examples. Let's say these mandibular teeth did not require treatment. They don't need crowns. They don't need anything. There is no cost to maintaining them and rolling the dice. We wouldn't take them out. But when you have to treat them, and there's cost involved, that's why you don't only have to do a risk-benefit analysis, you have to do a cost-benefit analysis. That comes after you do your PICO analysis. What is the problem? What are the interventions available to this patient? How do they compare? And what are the likely outcomes? Always in context of this patient. And then after you do that, then you see how the risk-benefit and cost-benefit modifies it. And sometimes you have to rethink. And if you get used to thinking like that, by the way, it goes really quick. Because when you see the patient, you process all that information immediately. Now, what Gary has asked me to do is introduce this to you, and he's also asking me to help him work on his module for implants on the software. And basically all I'm doing for him is giving him decision trees. He's just asking me, what do you consider? And I'm trying to give him decision trees. The difficult thing for Gary is how one interrelates to the other. Because you make a decision with your PICO analysis, then you look at cost benefit and risk benefit, and then sometimes you have to go back and change a couple of variables. So you go through that 2 or 3 times, and then you say, okay, this is what I'm going to do. And in that decision making, some teeth that are salvageable are going to be casualties. I say it as a joke when I say these teeth have good prognosis till they meet me, but how I make the decision actually is that way, and I think that is the way we're training our residents, and I think that's a rational way of making a decision. There's no always, there's no never, but it's always related to a series of questions that you're going to ask, and whoever has the longest list of questions is the champion. Yes, sir.
Look at this case.
Yes.
As endodontists, how do we look at a case like that and evaluate the risk of this sort of fracture in its relationship to how the occlusion is being managed? When I look at that, are there occlusal issues there that would predispose such a fracture?
Yes, there are occlusal issues. It could be occlusion, but in this case it was caries preceding occlusion. You know what I'm saying? So there is decay there, and that's why these things eventually broke. Occlusion is always an issue, okay? But this is a very difficult question to answer, and trust Gary to ask me the question. But I like presenting, but I don't like being assigned specific topics. So I was assigned a specific topic to lecture at the Canadian Academy of Restorative Dentistry. And it was on occlusion and implants. Okay, so the best slide of that was, I had a slide up here, it says, evidence based on occlusion with dental implant. And the slide was blank. There is no evidence that shows one way or the other how the occlusion on implants affects anything else. So how does it affect teeth? So when I have teeth and implants, how do I adjust the occlusion? Do I make it heavier on teeth, or do I make it heavier on implants? Or have you heard this story where some people say, if you restore a single tooth implant, you have to adjust it so the occlusion on the implant is light, because when you have periodontal ligament, when the patient closes, then everything will come to even occlusion. So you must be dreaming, you must be in Disneyland. Are you kidding? You can actually adjust for the compressibility of periodontal ligament that changes from day to night, night to day, and changes with attachment loss. And the opposing tooth doesn't move. You have it light, the opposing tooth is going to stay right where you tell it. You must be an idiot. But that's what they're teaching you. So now let's flip the story, which is what Gary is asking. How do you adjust the occlusion when everything is implants and you got 2 teeth? You want to make the implants light and overload the teeth? Or you just kind of adjust them all the same, and then, you know, whatever happens, happens. Because I don't have an answer. So we adjust them all to contact the same. And Gary, you're right, maybe there are changes because the implants don't move and the patients do. I mean, the teeth does. And there's also some evidence that our jaws remodel over time, and that can change the occlusion, but we don't know the rate, and we don't know how often we should bring these patients back to adjust the occlusion, and we don't know whether that has any ill effects, even if that does happen to the teeth or implants. So there's no simple answer. The problem with a lot of continuing education is that these guys who present are like rock stars, right? They don't care if they ever see you again. They just want to show you how good they are. I'm not interested in showing you that. What I'm interested in trying to show you is how we make decisions. right? But and then there's some things we have no answer to. So Gary, I mean, trust you to ask me something. I don't have an answer for that. I mean, no definitive answer. But those are the considerations that I'm telling you.
So that tooth was not in traumatic occlusion?
No. Basically, the only thing we do when we have these things, when we finish, we adjust the occlusion, we check for fremitus, we have the patient's tap. If there's no fremitus, we're good to go. That's the only thing we do. And anybody, any other expert in that I've presented to, I basically ask them, so what do you do? They don't know any more than I do. I mean, they know the same body of literature that I have. Some of them don't even read the literature, they just feel the force. So but I have, because I've had to look at it. I can tell you there's nothing. There's nothing. Okay? So this is our patient 2012, and she's back. And this is our patient after she's been reconstructed. You can see everything is gone. She's got a new dosage of antidepressants. She's very happy now, right? And then and this is how she looks. Everything is implant supported. The implants in the posterior are just as they were. They are just left there. Okay, and then let me ask you another question. Another reason why I brought this patient here. You see this bone loss around these implants? Is that peri-implantitis? Because I want you to go back and look at those two implants. It's pretty stable. Look at it. There's bone loss there in 2007. There's bone loss there in 2012. And it's the same in 2014. So just because you see some bone loss around the implant, if you don't have a history of it, which was my disagreement with Jean-Pierre, he would see a patient with bone loss, he said, that's peri-implant. I said, you can't say that. You have to know the history of the implant, you have to know whether it was grafted, you have to know whether it was immediately placed, and you have to see a progression of the bone loss. If you don't see that, you call it peri-implant bone loss, but it's not a disease process. Happens. But it can be stable over time, yes.
Do you think it has to do with the implant design here, these being...
Okay, I just got through saying that this implant design thing is total horseshit. There's no evidence. So if you have some evidence, let's talk about it, rather than what the implant company tells you, because I can tell you that according to the literature that I've read, there is no discernible difference that an implant design affects bone loss. The
question I was going to ask is, if this is a rough-end, highly tapered, big-threaded implant, do you think that bone loss on there would be more significant to the patient versus this, I like this machine, smaller thread?
I have the same answer. There isn't any discernible evidence, okay? The best evidence that you can see for that is near in Quirijnen from Belgium. They have a 15-year split mouth study. That's the best you can do. 2 machine screws on one side, external hex, 2 Astra implants on the other side. Astra has the most gimmicks that you can imagine. Threads to the top, different surface, platform switching. No difference after 15 years. And that's, I have the reference, I can give it to you. No, it's a humans. It's human study, split mouth, not a dog. The dogs, I mean, my dogs don't last 15 years, I don't know. Gary, you're into life extension now. He's got a new life extension module for TDO. So, no, but really there is no discernible evidence. Everything, if you, that's why implant companies hate me, okay? Because just disregard everything they say. If we never had an implant, so we used an implant, and then we got guidance from whatever company it was, okay? And then that implant worked, and worked very, very successfully, as I've shown you. So would a rational person change implants if they have something that works at a very high rate? You would think not, right? But everybody does. Except us. We didn't change. The connection that you see on all the implants up here are the old external hex connection that is supposed to be awful. And we are supposed to get screw loosening and all kinds of problems and leakage because and leakage, and the leakage is going to cause bone loss. I mean, look at all these patients. That is just something that the implant companies tell you, so you buy their stuff. What can I say? Say again?
Isn't this a very different situation from a single tooth implant? I mean, you're talking about...
Yes, it is. It is a different situation than single tooth implants. It is totally. If you have a single tooth implant and you want to use the internal connection implant, you can do that, and that implant will be more stable than an external hex implant, right? And if you don't know what you're doing and you don't adjust the occlusion well, you have a bigger fudge factor on those implants. But let me ask you a question. On an external hex implant that fits like this, if you don't do things carefully and there's overload on the implant, the screw will fracture, right? On an internal connection implant, as Rick showed several cases, what breaks? What breaks? And what happens? Basically, you're up the creek, no paddle. With the screw, you can just remove the screw. It's a pain in the ass, but then I can put another restoration on it. So you have to understand that. So the internal connection implants are developed for people that want to put tooth-looking abutments on there and cement when they do these bigger cases. So the internal connection implant, if you want to use it just for single teeth. You're absolutely correct. But how do you know that that patient, like many of these patients, is always going to be a single implant patient? What happens when they lose more teeth? You're going to have to deal with the internal connection implant. So when we treat patients, we see patients like this, they come back, we add implants, you have to manage them sometimes for a lifetime. It's not just a one-off deal and you're done. So has the internal connection implant advantages? Yes, for single teeth. If you are going to splint 2 implants, does the internal connection implant make any difference? No, because you have to bypass the internal connection. Now it becomes just like an external hex. Is there any reason not to splint implants? If you have 2 implants next to each other and no teeth in between, and you're restoring either as an individual tooth or FPD, there's no reason not to splint 2 implants. Biomechanically, it's a much, much stronger situation. That's why you can support the whole arch on 4 implants. Biomechanically, 1 implant, you have a twisting motion and movement everywhere. 2 implants, you eliminate most of the movements except for 1 rotation axis. 3 implants, everything is perfectly stable. You can hang a house on them. So that's what people don't understand about implants, because implants are not teeth. Even some of the cases that Rick showed, the implants, if they were restored at different times, I can see them being single units. But if they were restored at the same time, they should have been splintered. I don't understand why they weren't splintered. There's no reason not to splint them. You're not going to get interproximal decay. There's no decay to be had on implants. Right? So that's why implants are not teeth. It's a different mindset. It's a different way of thinking. It's a different way of thinking. And if you figure that out and you look at all these patients and you understand that we have a process of decision making, what the things are that drive the decision one way or the other, and then when we make the decision, yes, sometimes we remove teeth. We remove teeth. We do remove teeth. I mean, that's just the way it is. Do we make mistakes? Yes, we make mistakes. But based on my phone not ringing when these guys leave their 36 reconstructions, they're all like this. They're all really these extensive patients. My phone is ringing less and less and less, and almost never now. Okay? So we don't have to deal with these things. And I'm telling you, that's the point of view. And that is not, that last bit is just based on my experience, right? And how we make decisions. What validates that is we just had an alumni meeting. We have all the alumni come back, and they all talk about their practice experiences. And guess what? it's the same for them. They're not having to make and remake. These remakes are one of the most expensive things that you can imagine, right? A remake of one of the units, supporting units failing, is one of the most expensive things that you can imagine. So you ask a patient to turn over $50,000 to $60,000. When do you feel comfortable saying, do it all over again? Sorry, Mrs. Jones, couldn't help that. Let's do it all over again. When do you feel comfortable? If you hate the patient, it's no problem. If you actually like the patient, and I try most of the time to have a good relationship with the patients, it's uncomfortable. It's very uncomfortable. Right? Because it takes us 1.5 to 2 years to finish a reconstruction. And most of the time, the rubber dam is not in the mouth, so we have to speak to them. Okay, that's a joke, that's a joke. Okay? So, no dental disease on this patient, but mechanical. Okay, look at this patient. These two are mandibular teeth, by the way. This patient is totally overclosed. Right? Look carefully. So we are going to heroically reconstruct this patient. We're going to open the vertical, resect some bone. We need space, right? So we're going to get space by restorative space, increasing the vertical, resecting some bone, right? As you can see. And then we're going to place implants. And then what I want you to notice is on this side, the teeth are not endodontically treated. On this side, the teeth are endodontically treated. And the reason why this patient is here, why is the patient here, is the patient is high parafunction. High parafunction, all right? So here we go. This is the mandible, is the provisional restoration, is immediately loaded because the patient couldn't wear a removable prosthesis and he was traveling, and so we had to do it. So we took the risk, we did it. So it was in, and on the maxilla, we don't have ferrule, so we're going to get the ferrule. And so we're doing orthodontic eruption with the provisional in place and pericision so that the bone doesn't come with it. We need the tooth structure to come with it. So you can see we're cutting there and we're erupting. As you can see, we're exposing tooth structure, and we want a 1.5 millimeter ferrule circumferentially, right? So we do that. We put in cast posts, right? Whether you agree or don't agree, they are just as good or just as bad. The literature shows that. And then here's our completed reconstruction, and we go from here to here, and we're patting ourselves on the back and say, what fabulous result, you know. Patient loves us, everything is good. Let's think about publishing this in one of the journals. But before we can get our recall pictures, you get breakage, you get root splitting, and on the side where the teeth are endodontically treated. It's got nothing to do with the endo. Endo is good. It's just got to do with the remaining tooth structure. So that whole segment is going to be reconstructed with implants. Look, there's a fracture, right? If you look, there's a lot of wear. This is as the patient finished. Look at the amount of wear on this. This patient is high function. It's going through, I mean, that's not type 3 gold. That is gold palladium. It's pretty hard stuff. So, you know, so we have a problem. We made a mistake. Okay, we didn't recognize this. We didn't recognize this, right? And so how do we treat? Well, of course, implants are going all over the maxilla now. And then on the mandible, we're changing the restoration. Okay, that's the one time. I didn't bring the slides here. I have them on the computer. I can show you at lunch if you can be bothered. But basically, it's a titanium bar with acrylic teeth. And we made 2 titanium bars because you can CAD-CAM. So we told them, you're going to wear these teeth out maybe every year. Well, guess what? We also CAD-CAM the teeth. We don't have individual teeth now. We have a file of the whole mandibular arch. On the computer, you press a button, you split the file. The bottom half is titanium, the top half is acrylic. You just mill them on different pucks, and then they fit back on each other again. So he's basically wearing his own night guard now. So that's how we manage those patients. Maybe if we did that in the first place, he wouldn't have broken those teeth. Okay, but live and learn. So now we're learning. So we use acrylic as a safety valve. So we have ceramic against plastic. Okay, so I go through 12, right? Is anybody bored? You want to take a break and have lunch? No, I was hoping, but anyway. So now, Gary, this is toilet bowl white. This is my most favorite category of patients. Okay, I hope I don't offend anybody, but everybody has a favorite category of patients, right? What are your favorite category? Are they lawyers, family members? What are they? The ones that you have problems with. Yeah, exactly. So Gary and I have the same category of patients, and this is one of them. And unfortunately, I have many. These are MDs, physicians' wives, who don't work. Those who work is no problem. Those who don't work, they call up and they want to speak to me to make an appointment. And say, I don't have the appointment book. Let me put you back to the receptionist. What you want to say is, why the hell do you have to speak to me? But you can't do that because the spouse is actually pretty nice. So, the guy's a decent guy, you don't want to do anything. So anyway, this is one of them. She had a 4-unit fixed partial denture that she wanted replaced because she was missing the 2 centrals for a long time and went to the wrong practice, and they did premolar to premolar treatment on the maxilla and mandible. So it's pure white. And on the maxilla, they were trying to make an all ceramic fixed partial denture. But there wasn't enough interocclusal space, so it kept breaking. You see that? That's what you call a half moon fracture. So Glenn and Rick, if you remember your restorative dentistry, that's from tension on ceramic. So you get the half moon fracture, right? And this is the second or third fixed partial denture that she's had in there. And because there wasn't enough space, you see how bulky it has to be, this guy put composite on the posterior teeth to jack open her vertical dimension. So anyway, so she's kind of hysterical, she's uncomfortable, her jaw hurts. So I look at it a little bit more carefully. You see some chipping there, you see a fracture there. So she says, what can you do? And I say, well, let's try and get you comfortable, but I have to also grind on the bridge to close your jaw position, and then you can get comfortable. And she says, what happened to the bridge? I said, it's probably going to break one day. So all I'm going to do is take an impression, take your shade, and then I'll have, when it finally breaks, I will have a provisional ready. You come, I'll remove this and I'll cement that, and then we'll decide what to do. So I'm just hoping that she never comes back. But that never works for me. And she's back. So, oh, by the way, look, Gary, 1M1 and toilet bowl white. See? I took the shade just for you. Right? And that's what you see for the guys in dentistry today, where they're advertising and so on. Okay, so we remove the FPD and when it finally fractures, and now you have to make a decision. Do you want to put a FPD back on, or do you want to take the opportunity to place 2 implants and 2 single units? So you have to make that decision, right? So for me, and the way we do things now is that anytime we remove a fixed partial denture, we always offer the patient an option of restoring it with single units and implants, because everything can then fail by itself, right? Everything can fail by itself. So we discussed that with the patient, and she said, okay, let's have the implants placed. So we make a provisional restoration, still keeping these 2 teeth, and the implants are placed, again with this surgical guide. Very, this guy is, I think, one of the best implant surgeons that I work with. He's in Santa Monica. His name is Mark Handelsman. So Mark placed these implants on me. We worked for many years at the university together, and then he had to pay his kids' private tuition, so he couldn't stay. So anyway, so again, perfectly position, screw retain, and these two are still single units, and we're ready to proceed with our treatment, right? At this point, the patient says, you know, I'm having some pain in one of these lateral incisors, and the other one doesn't feel quite right. So send the patient to the endodontist, right? So one is testing delayed on the eyes test, and the other one is necrotic, right? So it's a good friend of mine, this endodontist. He says, what do you want to do? He doesn't just go ahead and do it. He says, what do you want to do? I said, well, the implants are integrated. Let me speak to the patient. So the discussion with the patient goes, you know, you can go through the expense of doing the endo in both teeth, 2 single crowns and the implant. Or we can remove the 2 teeth and have 2 pontics there. And she says, what is the advantage and disadvantage? So I say, well, this papilla here will diminish, this one and this one, right? Because you're going to lose this tooth, this will flatten out, right? So I explained that to her. Let me point on this screen. This papilla, the distal papilla and the distal papilla on both 7 and 10 will flatten out. She said, what else? I said, no, that's it. She said, what if I keep the teeth? I said, well, if you keep the teeth, these are the expenditures. And then if any one of them fracture, then we'll make a provisional cantilever over this side and wait for the healing after extraction. And then we'll make a new FPD cantilever on this side. And she says, what about the other tooth? I said, when that fractures, we'll do the same thing again. And I said, that's a pretty good deal for me because it's like an annuity. You know, I make the fixed partial denture 3 times. She says, what do you think? She says, let me think about it. So she disappears for a year. Next time she comes back with her husband, because her husband is the real doctor. So he comes in and I explain everything to him and he looks and says, do what the man says, I'm going to wait for you in the car. True story. I hope it doesn't offend anybody, but it's true. So we take the tooth out. But if you look at these teeth, because they put an all ceramic fixed partial denture on it, they weren't very big to start with. They really had to prepare the teeth heavily. Right? So it's not a big surprise that there was a pulpal issue. Okay? Maybe it didn't help that I had a provisional on it for 4 or 5 months, right? But maybe it didn't help, I don't know. But it might have been on its way down anyway because that fixed partial denture was replaced 2 or 3 times before that. Yes, Gary.
More of a patella issue. What about just bearing the roots?
Oh, I have examples of that. That is a nightmare. Bearing the roots, what Dr. Carr is talking about is called root banking, meaning you keep this tooth here and you kind of do endo and then you cut the root. Actually, some people are doing it without doing endo, by the way.
That's what I mean.
Yeah. But you can do that. But these teeth are already testing so-so. I think if they're vital, you can. That's when you cut them. These teeth have to have endo done, right? So the difficult thing is getting the soft tissue to close on top of that. So we've done that. I've done that a couple of times, and more than a couple of times. And then it's just not worth the effort and time, and it really takes a lot of time. The patient has to go and come back every 6 weeks, and then you see if it doesn't cover, you reduce the pontic, and then after a while you start reducing the root, and then after a while he says, I think this thing is already all epithelium. Then you try and make it bleed again. You put a handpiece in there, and actually I don't know what the hell I'm doing. So I don't have the formula. Somebody out there might have the formula, but I'm just telling you the way it is. We've tried it. It's nice to talk about. I actually have a couple of examples. When I do a real continuing education thing where I just want to show off and show everybody how good I am, I show those cases without telling anybody the background. Like, hey, this happens all the time. Anybody that does CE does that. So, make sure you get somebody that, like Gary says, I don't want anything sugar-coated. Just give these guys the lowdown. So that's what you're getting, right? So, that's basically, it kind of works, but
The idea is good, but it's a pain in the ass.
Would you try it if it was a significant issue with the patella?
Yes.
In a high aesthetic case?
Yes.
The 2 times no, I don't care about movie stars. I don't want to treat them. The producers are pretty good people. When you treat the producers, they tell you all kinds of stories about the actors and actresses. They're great. But the actors and actresses themselves, they are crazy. I mean, they are psycho, some of them. So forget that. You don't want to treat them. The 2 times I've done them were a dentist's son and a dentist's wife. Then I was happy to take the trouble to do it. I have those documented if you want to see those. But routinely I wouldn't do it. If you're running a practice, it's just to make friends to do that. You're not going to make money. Okay? Yes.
If you knew where you're going to end up with 4 crowns supported by 2 implants, is it easier aesthetically if they're the laterals rather than?
Yes, always. That's a very good question. It is much easier to control the aesthetics around pontics than it is around implants. So the preferred positions are always 7 and 10. But I'm going to show you a series of 8 and 9. Only to show you that we don't make decisions the same way all the time. Okay? So, yes. 4 implants is overkill. And when you place implants close to each other, you always get a measure of circumferential bone loss around an implant, right? And you can blame that on a plethora of things. Some people think there's a biologic width issue, which I think is horseshit. I think it's just simply leakage. So you're going to have leakage at the abutment, and all implants leak. The only implants that don't leak are one-piece implants, which I think have no place in implant dentistry. So the moment you have a connection, it leaks. So you're going to get circumferential bone loss, right? If the implants get too close, those 2 circumferential areas overlap and you get a huge bone loss in between. So you don't want to get the implants too close, and more implants is not necessarily better. Okay? So in this particular situation, adding implants doesn't help anything. Doesn't help anything, except the implant surgeon's pocket. Say again?
He has to eat also.
Yeah, but that's not my problem. That's not my problem. Okay, so as painful as it is to you, we extracted those teeth. And so you can pay attention to this papilla and this papilla. That's the provisional. After 1 year, you see how yellow it is, right? And so we just make those pontics. This is one situation. If you want, you can put something in the socket. Keep the dimension if you want, right? And this is the completed restoration just with the cantilever. And this is the restoration in the mouth. So that papilla and that papilla diminished. Was that horrible for this patient? I think it was okay. It's symmetrical. And that's a very stable restoration. That's been in there for almost 15 years. Patient came back for a recall. It's fine, perfect, happy, still married. So, she's happy. And again, the other thing I want to tell you is that every time you look back there, we are screw retaining these things. We are screw retaining everything. I do not understand why anybody doesn't do that. 90% of the restorations done in the US are cemented. I think the only 10% is the people from USC. Okay? Always, always. And you know what I love? You go to these implant meetings with surgeons and they say, you can't place those things to emerge in the cingulum and the occlusal surface. I said, really? We have residents who do that all the time. Anybody that misses the cingulum or occlusal surface in the pros lab, there's a chart there. It's called the wall of shame. Anybody that misses, we put their name up, right? So instead of a plus for having a good landing like the pilots, they get a minus for missing the target on these implants. And you can do it. It's just a matter of how you're oriented and how you train. Okay? So this is another patient, right? This is another patient. I was too lazy to dig up the PA. But if you look carefully here, you'll see that both the centrals have severe bone loss periodontally, right? They're both periodontally involved. And so we're going to extract those teeth. And if you look carefully This is after extraction. If you look carefully, again, at the back, I don't know whether you can see, there's also a lot of attachment loss on the lateral incisor. Everybody, can you see that from the back? So we're doing the same thing here, right? We're doing the same. Just ignore this, okay? I know all of you are looking at this. Please focus on this. I mean, come on. I should have cropped all that out. But I do want to show you that we do a full mouth exam. Okay? We did address that. Don't worry. Okay, we did address that. So here is this segment we're talking about, right? So these teeth have already been restored, right? You can see there are veneers on them. And so this is the patient, and another close-up of the radiograph. So we are going to prep these two teeth temporarily. They're only to hold the temporary. So this is a provisional restoration in place, right? And then we're going to place implants. You can see you're going to lose a lot of attachment, right? Because there's already periodontal attachment loss. We're not looking to regenerate that, right? Again, part of the equation I didn't talk about, but part of our evaluation is the patient does not have a high lip line. So we're not even going to bother with any fancy procedures up there, right? So this is our patient. She's a pretty nice lady. And after all the healing, we extract those two teeth because they had so much periodontal bone loss, and we are cantilevering. And we put in some pink porcelain to match, and you'll see that we can do that really well now. And the restorations are going to look pretty nice in her mouth. And that's the restoration, right? They're cantilevered. Now, let me ask you a question and be honest. On the first case, when I extracted two teeth that needed endo, some of you felt very uncomfortable, right? The next case, we're extracting two teeth because of periodontal disease. You feel just as uncomfortable, or now you're happy? So, really, I mean, if you're honest with yourself and you look at that, for us as restorative dentists, do we see a difference? No. All we care about is the predictability of this segmental reconstruction over time. That's all we care about. Nothing against you, nothing against the periodontist. Yes?
Just looking at some of the stuff you did, really nice fixed crosswork in college, and you see it failing and late phase.
Yes.
Given the fact that caries, fractures and everything, all teeth are vulnerable, medication, longevity of patients, would you say that it's incumbent on all endodontists and referring dentists to have lower expectations and give your patients lower expectations for teeth that are going to be extensively restored, even if you don't have all the other issues, just because of what you see?
The question is it, should we, or we should, no, let me answer the question. Should we lower patients' expectations when we are performing endo on teeth and keeping teeth? The answer is yes, right? But this is how you should approach it. They ask you, first of all, the patient is here either because there's an infection or there's pain. And you can say, Mrs. Jones, we're going to get you out of pain. And we're going to get you out of pain as conservatively as possible to your tooth. But what you have to understand is that the less tooth structure there is, the better chance there is for you to break the tooth. I am confident that the root canal is going to clean up the infection and get you out of pain, but I cannot predict what's going to happen to the tooth. And that is just the honest truth. I don't think that will detract any patient. So they say, well, should I have an implant? And you say, well, an implant comes with risks and benefits. See, you should tell them the truth. An implant is stronger than your tooth, but it's harder to make it look like a tooth. And your tooth is connected to your jawbone. There's a 5% implant. There's a 5% chance that the implant will not connect to your jawbone. That's the truth. There's no lie in there. And most of the patients will accept the risk of having the endo, and you have not lied to them. And if it's a single tooth, it is not affecting another reconstruction. A lot of the cases that Rick showed, I'm perfectly comfortable with doing that. Those are the patients that I send to endodontists. It is when I'm placing implants in anywhere close to the area. That's when I get very, what you would consider aggressive, I don't consider it aggressive, at removing teeth. Because I go through the analysis again. Problem, intervention, comparison, outcome. And it is not related to one tooth. It is related to the segment and the reconstruction. And then risk-benefit, cost-benefit. And then collectively, I'm going to make a decision, and here's where you're going to get uncomfortable. Your specialty may be out of the loop. You'll never see the patient. Because I'm going to make the decision, and if the decision goes against keeping the tooth, I'm making the decision. If you want to be in the decision, very happy to have you in the decision because I don't want to make a mistake. I will make fewer mistakes with you as part of the team, but it has to change at your educational level. It has to change at your educational level. Right? Some of you are going to have lunch together out of my earshot and say, that guy is such an ass. I mean, that's fine, no problem. No problem. I don't have a problem. You know, I'll tell you what happened. Gary came to USC with Steve Berg showing the minimally invasive endo stuff. I had the endo residents there. After a few weeks, the murmurings among the endo residents and faculty, oh, that you can't do that. That, you know, nobody practices like that. So no, my expectations are very low, okay? So no. I mean, but really, if anybody has any problem with what I'm saying, or disagreement, let's talk it out. Let's talk it out. Yes?
In the cost benefit analysis,
yes,
in a segmental reconstruction, what would you consider, say, an implant would fail? I mean,
say what would?
An implant would fail in that particular segment.
Yes.
Okay, so here, let me answer the question this way. 5% or so of the implants will not integrate, right? Everybody agrees about that number, because even when our undergrads place the implant, the integration rate of the implant is 93%, is between 93 and 94%. Undergrads, first timers, people who don't know what the hell they're doing, okay? And they do it with a guided, computer guided sleeve, right? So it's a very, very high success rate, but they have good faculty guiding them, right? So most of the time for implants, I don't invest the money, and the patient doesn't invest the money in the reconstruction, because most of the failures happen at that time. Late failures with implants are not very common at all. The literature will bear that out for you. Okay? Are not very common at all. So the money has not been put in there. The difference with endodontically treated teeth is the moment the patient is asymptomatic, we go. And then if something happens, blows up in our face. Yes?
The problem with loss of proprioception, loss of PDL.
Okay, the person who wrote for that, and I'm very familiar with that, is a guy called Van Steenberg, okay? Van Steenberg coined the term osseoperception. Okay, osseoperception. So Van Steenberg postulates, and he's got several articles, that when you remove a tooth, those of you who have restored implants, I know Glenn has restored some implants, if you have porcelain chipping, it happens very early in the patient's experience of implants. And so it could be that we didn't adjust the occlusion well enough, or the patient didn't know when to stop chomping on the tooth. And that's what they talk about perception. So Van Steenberg says when you have amputees and they recently have artificial legs, they can walk on carpet and cement and sand, they can't tell the difference. But after a couple of years, they can tell the difference, just from conduction of the prosthesis. He's postulating that the same thing happens with teeth. And so that's just a theory, we don't know, but it's reasonable to connect them because of the people with the limb problems. But how does it affect the jaw, the way people chew and everything else? They've actually looked at that with tracking stuff, the jaw motion with a magnet here, and looked at all kinds of things. They haven't been able to show a discernible difference. The only thing that they have showed a difference that patients can learn is they have these different size wires, and so opposing teeth, the patient doesn't know. They put them in the patient's mouth and they ask them, is this bigger, is this smaller, is this bigger, is this smaller? And when it's teeth opposing teeth, it's the most accurate. When it's a tooth opposing implant, it's the next most accurate. When it's implant opposing implant, we're talking fixed restorations, is the next. And then comes all the removable prostheses, overdenture, denture, and so on. So implants, for sure, are less sensitive than teeth. But then when they repeat the study after 1 or 2 years, the sensitivity becomes better, but not as good as teeth opposing teeth. So is it worth keeping a tooth just for that proprioception? The answer is, I don't know. Is there less proprioception on implants? On implants than teeth? Yes, but it improves over time. I don't have any other answer for you. Okay, so Gary, I'm over time. So shall we cut it off? I can. Okay, let's just cut it off. I can. Okay.